Good morning, ladies and gentlemen. May I ask that we take our seats so we can commence in 1 minute, please? Thank you. Good morning, colleagues. Good morning, ladies and gentlemen. Thank you for saying that. Good morning, ladies and gentlemen. And first of all, I trust that you had a good evening, and I understood that most of you who went to the dinner had nothing but absolute complimentaries for the dinner, so congratulations on that. I found myself an excellent Indian restaurant somewhere on the street, and it was excellent. But welcome to all of you to day 2 of the 4th board meeting of the G4 Alliance. It is my absolute honor to be joining you again today to chair this meeting in the role of chair of the G4 Alliance's Honorary Council. We are also delighted to welcome many first-time meeting participants, as well as, of course, the returning members. Day 1 of the board meeting provided us with the opportunity to review our first year and a half of operations and reflect on the growth and the development of the Alliance since we first established this network back in December 2015. Today's board agenda will provide us with the opportunity to review feedback from yesterday's breakout committee sessions. We will also receive updates from our G4 Key Framework Elements working groups and to participate in breakout sessions to discuss our proposed global unifying targets and next steps for working groups. We are also honored to be welcoming special guests, the Honorable Dr. Rida El Oakley, Minister of Health of Libya, and Dr. Emmanuel Makassa, Counselor Health of the Permanent Mission of the Republic of Zambia. Finally, we will have the opportunity to review committee assignments and to discuss new business. So we do have a fairly long day, but I am very confident, if not convicted, that we will end on a high and a very clear path for the next steps to go forward. I would also like to take this opportunity at this point. We have an additional new member amongst us this morning in the form of Demetrius Linus of Prolepsis Dimitrios. Where are you? Welcome, sir. And we will do the needful as regards your presentation later on. But welcome, and thank you for joining us. Is there any other new member whom we may not have acknowledged this morning? Good. Before we proceed any further, I would like to give the floor to Ms. Lisa Afra of Physicians for Peace, who will take us through a brief recap of day 1 before we set the stage for day 2. Lisa, the floor is yours, please.
Good morning, thank you. Good morning, ladies and gentlemen. I am so elated to be a part of this magnificent alliance, sharing, learning, advocating, collaborating, and finding solutions to help solve the problem of the lack of surgical access across the world. I have been asked to recap yesterday's session, and in the spirit of full transparency and to show you all how self-aware I am certainly not going to be able to recap the way His Majesty did yesterday evening, so please forgive. As my first time here with this esteemed group, I enjoyed listening to all the reports given and even took copious notes between Faizan and Mira, Dana and Albulina, the various committee chairs, and of course Brendan's first official address. Yesterday was spectacularly detailed. And let it not go unmentioned how delightful it was to listen to the introduction of all of you, different organizations, countries, missions, and personalities represented. All of us here because we share the same desire to see safe surgical care for 80% of the world by 2030. We've heard the haunting facts about the lack of access to surgical care taking the lives of millions around the world each year, and we are all here to be a part of the solution. We will do this with consistent messaging, proper funding, sound finances, stable bylaws, an active board, and a truly transformative leadership team. I witnessed this team yesterday as we were introduced to committee chairs who were concise yet thorough in their reports, and breakout sessions where innovative thinking and collaboration were in abundance. We were treated to time with Dr. Walter Johnson and heard firsthand the hope for and realities surrounding Resolution 6815, clearly something to be so very proud of. It was a day of progress and one day closer to 2030. We are one day closer to reaching our goal. Thank you.
And I thank you, Lisa, and thank you very much for the very undeserved promotion. And thank you very much for the very concise recap of yesterday's proceedings. Colleagues, before we move on to item 2 on today's agenda, we just have a couple matters of housekeeping. And first, let me introduce you to, you may have seen outside yesterday, and thanks to those of you who participated in a campaign being launched by the G4 Alliance. It's called the I Commit to Surgery campaign. It's hashtag I Commit to Surgery. You may have seen some of these stuck on the walls as you entered, just above the area for registration. And as an organization that focuses on advocacy as one of its key pillars, the G4 Alliance's team is pleased to be rolling out this new campaign. And again, it's the hashtag I Commit to Surgery. We welcome you to share your comments by taking one of the markers or a fairly broad ink observable pen and writing your comments that you think would be supportive of the I Commit team, of the I Commit to Surgery campaign. Perhaps if I may make a suggestion, I know that we have a step and repeat located outside. I know some of you may have been taking photographs in front of it. It may be a great idea to write your comments on the I Commit to Surgery campaign, and you go in front of the step and repeat, hashtag it, handle it, and launch it out, and we'll be more than happy, I'm sure, to advertise this further. And I would also suggest that tomorrow, during the side event at 6 p.m., it will be shown, and we will also have Surgery Saves, prioritizing surgical care as part of national health plans also being which is the title of the event. We'll also be showing some of your presentations during that time frame. And of course, Dr. Abdullah did mention to you yesterday as regards this event tomorrow, and he didn't extend the invitation, I recall, to all participants. So I think your appreciation in terms of our appreciation in terms of your presence there would be very much welcomed. Having said that, I think yesterday we went through the House rules. If we could keep our phones on the hush mode. And we don't have any major items of voting to be had, except to say that those of you with the permanent member status, i.e. the red placards in front of you, you are allowed to actively participate. Those of you with the black who are observers, and I would also suggest Alan Finley, having mentioned it to me, thank you. It was returned. I'm happy to see that. You'll be more than welcome to participate. And again, just a reminder, when you wish to take the floor, if you can raise your placards, put it up in the vertical position, and the questions or comments will be taken in the order in which it was received. And we would more than welcome this type of interactive discourse we have been having since yesterday. Having said that, ladies and gentlemen, we will be moving on to agenda item 2 on the revised agenda for today, and that will be the committee reports. And just to remind you, as we said yesterday in closing, each committee will be given 3 minutes to give a report, and then we will have 2 minutes of Q&A for the delivery of these following the delivery of these reports. I would like to welcome, first of all, if I may yield the floor to the Committee on Governance to start us off today. Erin and/or Erica, the floor is yours.
Thank you so much, Ambassador Parson. And our report is going to be short since we had a lengthy discussion yesterday to address most of the governance issues. So I'll just thank the Governance Committee and our new members as well, who we look forward to working with for all of your help. And remind everyone that yesterday we passed the amended bylaws, which we'll be working with our council to do that final amendment with the language we discussed yesterday, and we'll recirculate those bylaws. We'll also be developing a whistleblower policy as recommended. If there are any other governance-related suggestions that come up during the meeting or just during your general course of work, please don't hesitate to reach out to us, and we can figure out how to address those and whether any policies or additional documents need to be developed. And the last thing I would just highlight again is that we're energizing the nominating committee, which is going to be a really important group to put together our permanent board. Being on the nominating committee does not preclude you from being a nominee. It would just mean that you couldn't participate in discussions about your candidacy as a potential slate member. So I would ask all of you to continue to think about helping on that group. And I think Erica and I are hoping to meet with people informally at lunch, just briefly if they have an interest. So keep an eye out for us then. But we'd be happy to answer any questions.
Well, thank you very much, Erin, for keeping that so brief. I would happily open the floor to anyone wishing to question the chair of the co-chairs of the governance committee, or raise any issues that you would like to see highlighted by this committee. The floor is open. Well, Erin, it seems as though your team did a fantastic job. There are no questions or comments to be had, so we thank you for your presentation. And keeping in the spirit of ladies first, I wish to ask Abilina of the membership committee if she wishes to take the floor. Sorry, Susie, you can take the floor on behalf of that committee. Thank you.
Thank you very much, Ambassador. So we yesterday had a very, very good meeting and a discussion about how to improve our membership above what Albelina has done, and she's done a fantastic job going from 22 to 70. And so one of the things we looked around was how could we propose a strategy of how to take things forward. One of the issues that arose was, the clarity of our values as we'd use them as a format of proposal to other groups, and then to actually look at specific groups that we wish to really encourage to be part of our membership. So going after corporations and looking at what would make them wish to be part of us. So developing a very clear strategy, a clear vision of what we wish to do in accountability, and really looking at programmatic issues, which is what most apparently corporations would be keen to hear. On top of that, there was a suggestion about developing an ambassadorship roles, not just for all of us here, but actually taking it further and really developing a very strong, not just informal position, but actually quite a strong sort of focal point. One other suggestion that came up was to look at our website and to develop packages for different organizations and groups. So things that would matter to certain groups may not matter to others, and really sort of to drive that home and develop a very clear, focused approach to each group we're approaching. There was also discussion about membership fees, and at the moment we have a stratified approach to that. And there was a discussion as to how we could encourage more participants from lower and middle income countries to be part of what we do, but equally to do it so that they feel empowered and to feel valued within this setting, and what sort of fees we could look at or structures we could look at. And one suggestion, for instance, came up such as having a buddy system, so another organization which may be able to support an LMIC group to come through, an organization from an LMIC group to come forward and to support them through the process of being with us. Because one of the things that the committee felt was we needed more people from that environment at the table to be involved in decision making and taking things forward. We felt that we needed a regional spread as well, so we needed people to be working in different arenas. So we needed people within the committee to work with other members of the council in looking where we could reach, how far we could reach, and developing sort of a strategy for that. And then looking at really not just the numbers, but the quality of the people we can bring to the table and what we're missing. So one of the suggestions was our membership is very heavy on doctors. We've got some on nurses, but we haven't got engineers, for instance, or architects, and more biomedical components to our setup. And in fact, more nursing organizations, midwifery, etc. We need them all at the table. So we need to actually look at a very good mix of all those individuals and bringing them forward. So that's sort of a brief synopsis of what we did yesterday. It was a very good discussion, and I appreciate all the members of the committee who were so forthcoming with the ideas. Happy to take questions.
I thank you very much, Susie, for your intervention and your report on the membership committee. I would happily open the floor this time to anyone wishing to make comments or ask questions. Susie, I see there is no request at the moment, but if I may ask a question as well, please, or make us, what discussions did you have, if any, or plans, if any, to sort of really create the genetic diversity at a civil society level to reflect social inclusion and what we are trying to achieve here?
So we thought, one of the things we thought we must have is this strategic sort of perspective, and to look at the whole broad aspect of what we're doing, because that wasn't very clear from our website exactly what we were trying to achieve with all the members. So one of the options is, we know we've got a lot of expertise in the room with a lot of access to lots of groups, civil society groups, but across the board. And we haven't harnessed all of that. So we thought that will be our starting point. But then really revamping, and one of the suggestions to revamp the membership site the aspect of our website to really drive home the message to all groups, because at the moment it's not very clear. So we felt that would be step number one. But then really active engagement by every member in the room with their own teams that they work with in their own environments, and bringing those in towards us.
Good, thank you. Any questions, further questions or comments on that group? Dr. Abdullah?
I just want to, good morning, everyone. I want to point out that the Executive Committee also felt that this conversation around engagement of LMIC stakeholders is important enough that on the open plenary session, which will happen at the end of the day, 7.5, we'll be talking about this again, particularly the travel for our LMIC board members. So just stay tuned.
Thank you, Dr. Abdullah, for your intervention. Sir, I see you requesting the floor. The floor is yours.
Yeah, my comment, according to what she has mentioned, I have not heard about the member limitations. What is the maximum number of the limit? Thank you.
So we didn't discuss a maximum number. Albertina told us there were 2,000 organizations we could potentially tap. I'm not sure we're going to be able to tap all 2,000, but no, we didn't discuss a maximum number.
That was something actually that came up during the governance session and has come up in the past. And at this stage, the feeling is that there, is not really a limit that should be put on the number. The discussion also then turned towards, what do we need to have more stringent guidelines on what members are able to join? Because right now, as the bylaws outline, they really need to be committed to the goals and the mission of the organization and have an interest in global surgery. So I think we feel comfortable with the direction that we're moving now. I think we're going to need to rely on the G4 team, though, especially the membership team, to help us understand if we start seeing groups that seem like they may not necessarily fit with our mission, that we may need to reevaluate. But for now, using the bylaws and their direction on who can join the permanent council and not having a cap was where the governance committee felt we should be as a member organization.
Thank you. I see there are two requests to the floor. We'll take these two and then move to the other committee. I'm not sure who went first. I'll yield to McGee. The floor is yours.
Thank you, and thank you for that report. I was just wondering whether your committee had come up with any novel ideas at attracting the large professional organisations, societies that we have so far been relatively unsuccessful, so associations of anaesthesia, colleges of surgery, etc.
So a lot of us have tried, and everybody was talking about various experiences. And I think the only thing is really, one of the things we found out was that perhaps we weren't always targeting the right people within the organizations. Many of the organizations now have global health bodies and global health associations and teams. So we thought the first step is really to go back to those organizations, but go in through the global health door rather than through the front door of the professional society. So that's one thing we thought. And the other thing, which is the old-fashioned way, face-to-face, because a lot of it has been done by email. So this is where we'll be calling on members of the society, all the professional societies here, wherever you are, to go in face-to-face and speak to the team and just explain the situation. Because up until now, it has been very much an email contact, which doesn't always work. So.
Did the committee discuss regionalization of membership? By that I mean, are we looking to make an impact in, say, South America, which I don't think is represented here at all, actually, and other parts of the world? It seems that we're focusing most of our efforts right now in some very specific regional areas.
This is part of the reason we talked about regional, almost targeting, really to go into different regions. And I think one of the issues is that many of the groups working around the table, most of the groups are working predominantly in Africa and parts of Asia. So it's a question of really expanding that view and bringing all the people from that environment. So we haven't discussed it fully, but we are looking at how to achieve that.
Yes, sir. You can have the floor.
So this is more of a comment than necessarily a question. You know, one of the ways that you could expand regionalization is if you decide to hold the next board meeting, say, in Sao Paulo or Bogota or anywhere but Venezuela.
Thank you for your comment. As a diplomat, I'm not allowed to respond to that, but I appreciate it. Thank you. And I appreciate all the comments and questions to the membership committee. I wish to move to the next presentation by the External Relations and Communications Committee. Would the chair, Sarah, please take responsibility for that. Thank you.
Thank you so much. Next slide, please. So we had a robust meeting, and thank you so much for the participants and to Tiggy and everyone who came. It was great. And as I mentioned in our communications presentation the day before, we've kind of have defined communications, and it's basically to raise awareness. And the methods we do that are by creating effective key messaging and communication materials and building an audience through media. We also kind of defined why we're doing it, and so that's on this slide. Next slide. So what we hadn't done before is really look at what external relations means and what its mandate should be. And so where we landed, and welcome more questions and comments, is to basically develop strategic alliances and also policy, advocacy, government strategies, you know, what the right word is, I'm not quite sure, that for both multilaterals, for high-income countries, and for low-income countries, and to identify those synergies and targets, and then engaging those key stakeholders and creating more champions. And this, some of the, where the difference is more in the methods, which is kind of mapping and mining connections, which Susie just talked about a lot in membership as well. There's a lot of overlap in many of the things that you said. And then meeting and events with key stakeholders. We feel like the G4 Alliance has done a great job with a lot of the meetings with key stakeholders so far, but it hasn't particularly been super strategic. It's been opportunistic and wonderful at the same time, but I think there's more that we can do with depth if we go there. So next slide, please. So what we're recommending, rather than at this juncture, rather than starting a whole nother committee, is for the next 6 months, let's just kind of continue, because there is so much overlap between communications and external relations, but kind of divide our mandate up just a little bit. So that's what we recommend. Next slide, please. So moving forward, we'd love to select subcommittee chairs. And I use the word select because I wanted to check with governance to see, is this a point? You know, we're not quite sure what we do with subcommittees there. And then we'll hold some regular calls. We wanted to define G4's value proposition for members, back to kind of what Susie was talking about. And we also talked about revamping the communications with the website and things like that, as well as the toolkit, and doing some more tailored and targeting messaging, which you were just mentioning that membership was wanting, as well as doing some advocacy training. We had just a tiny bit from Izzy yesterday, and there's so much more that we could do. And then kind of do a little bit more specific policy strategies with stakeholders, and which that will certainly dovetail into the other committees and working groups. So I welcome any questions, and I welcome my Vice Chair Tiggy to certainly respond to any questions as well.
Thank you, Susie, and thank you, Tiggy, for being willing to do so. Any questions or comments? to the, Erica?
I'll just respond on the question about governance, as it's not a separate committee and not really even a subcommittee. It's more of a, we'll call it an interest group within the committee. There's no procedural basis for which you need to follow any process. So if someone's interested, that's great. And otherwise, you can kind of select at your will who it will be.
Thank you. And can we move it back to the one slide before this? Because I think that might be easy. There we go.
Thank you, and thanks, Sarah, for the great presentation. I think one important thing that sort of overlaps the membership group and this group is we talked about looking at the current members and doing some kind of very short survey about who you work with on a regular basis or what connections exist among this group that might be kind of the low-hanging fruit that we can connect with and reach out to, whether they're professional associations or other coalitions, other alliances that may have similar interest as this group. And I think especially, I was talking to somebody this morning about sort of who's working on UHC, and can we connect with them and better align our goals with them, or in the case of intra-health workforce issues in general, and really join forces to make us stronger, whether it's to gather new members or just to align advocacy messaging and targets. Thank you.
Thank you. Mr. McGee?
Yeah, sorry, this is just a relatively trivial remark, and it relates more to communications than anything else. And I think probably a lot of the men in the room probably fell in love with Scarlett Johansson in Her, but on the other hand, most of us have a bit of a hate relationship with the voice on our sat-navs in our car. And the reason why I mention that is that we had some excellent videos yesterday, and the committee are really, the organisation are really to be commended on the outstanding value and state of those. But G4 is a global alliance, and I wonder, should some of the voiceovers have a voice which is sometimes south of the equator or even east of the Atlantic? It's just something to think of.
Point well taken, Mr. McGee. As I have you on the floor, ladies and gentlemen, Mr. McGee was invited to join this particular committee with who will be bringing a focus on the in-country legislative agenda, and I appreciate your acceptance of the responsibility, and we look forward to your input. And having said that, I thank all of you for the questions for the External Relations and Communications Committee. We would move on to Dr. Lane's presentation on finance and audit, and may I just remind you, please, for the benefit of our newly inducted members and the online visitors, if you can say your name and your organization when you actually take the floor. Thank you. Dr. Lane, the floor is yours, please.
Good morning, everybody. Thank you very much, Mr. Ambassador. Finance and auditing, I will make this notified as much as possible, or notated as much as possible. We decided that we've got to start planning the budget for next year and possibly even the year after as soon as possible. We overviewed our current structure. As you know, Mira is currently the staff person responsible for accounting, but there is to be transition to Brendan, sitting on my right, in I think something like -1 days. We use QuickBooks software, as we were asked to explain that. We will be bringing an external auditor on to manage finances and the payroll. Given the nature of G4, which is a 501c3, the type of accounting structure is different. 501c3 status is difficult to achieve and to hold onto in Washington, D.C. And so it was pointed out that we must maintain rigidity of financial and administrative structure. We've got to make sure that linkages between the work plan and the program budget are kept. We considered the question of offices. The approved office address is in New York, our registered address is in DC, and we work in Chicago. paying and filing taxes, although not particularly high, in all 3 states. It was pointed out that the office space in Chicago is a given space, that's given in inverted commas, at Northwestern, but potentially, and in the not too distant future, we shall have to start paying rent at about $800 to $1,000 per month. And we therefore decided that we've got to be clear about where our official office is, because clearly we don't want to have to go on paying taxes in 3 states unnecessarily. It was thought probable that we ought to choose DC. A proposition was put forward to change the name to the Finance and Administration Committee, as opposed to the Finance and Auditing Committee. And this committee was to make recommendations to the Permanent Council. And we should also be aware of US OFAC, which stands for Office of Foreign Assets and Control, whose primary function is to catch money laundering. Well, they'll be lucky with our amount of money anyway. We, as I say, discussed the location. The chair and founder is based in Chicago, which was helpful and still is in its infancy phases. But proposed movement to DC, as I've already said, where it's registered as a 501c, should be considered seriously. Taxes change if location is in the city or in the suburbs. You can see that I was being educated in US tax law fairly swiftly. On the development side, that's another report, sorry. Thank you, Mr. Chairman.
Thank you very much, Dr. Lin. Your content and your articulation made my Sunday morning. Thank you. I wish to open the floor for any comments or questions that you may have for the Finance and Auditing Committee, please. The floor is yours. McGee? Yes, sir. The floor is yours.
Can I just get some understanding from Bob or anyone who knows more about it? As a 501c3, why would you be paying taxes? What are you paying taxes on? And how would you vote? I don't understand why you're paying taxes in 3 states.
I have not, in fact, been that educated yet. Can I ask our legal partner?
Not a practicing lawyer in this context for everyone's reference, but my and this is not an area of expertise that I have, my understanding is that yes, we, as a 501c3 in the U.S., we are exempt from paying taxes, so this shouldn't be an issue, but I'm happy to also guide people towards Section 3.01 of the bylaws, which does consider where our offices are, and that mandates that the principal office of the corporation shall be located within or without the District of Columbia at such place as the Board of Directors shall from time to time designate. And then the corporation may maintain additional offices at other places within or without the District of Columbia as the Board of Directors may designate. So we have a fair amount of autonomy to decide where we are located. But I do think that this is, I would just note personally, an important discussion as we consider who we are and what we want to be and where our primary partners and staff are. I would think that DC and Geneva and some other locations are certainly worthy of consideration.
Thank you, Aaron. Dr. Abdullah, you wish to take the floor?
Yeah, I think Mira was going to make a comment about the specifics around the taxes, but I do want to comment on location to be very transparent about it. I think that you have to remember 18 months ago, this organization did not exist. And we've hired 4 employees in 18 months. So we're really in an incredible startup phase and mode. And there's no question that in the long term, I think we all, and with the officers and the executive committee, we've discussed this, intend that as the Alliance has the financial and fiscal strength to have offices primarily in New York around the UN activities in DC and Geneva. The good news is the world has become a very virtual place, so even though the staff has basically been in Chicago, and as was mentioned, they're in a northwestern space. Me as the chair, I'm very excited because, and I think it's, it's important for everybody to know, naturally, around right now it's about 1 to 2 hours a day of activity, and some days, full days of activity to around really planning and supporting from my perspective as a chair of the Alliance activities at the minimum. And that's very taxing to me personally. And that's one of the reasons I'm incredibly excited to have Brendan now to really transition that to him. So that transition period, we don't know, hopefully it will be about 6 months as the best guess, 3 to 6 months, and then where the Alliance goes is really in his hands from my perspective. But I think also you have to remember that Brendan relocated his family. So we can't say to Brendan, you know what, come to Chicago for 6 months, and then 6 months later your daughters are going to change schools. So I think we should just I'm being very transparent about it. We should have that confidence in we've hired the very capable person, and that he over time, either through his own physical presence and moving the central office where he feels it is appropriate, but I think we should empower him that it's his decision in the future. And that also may mean he may open offices if things go the way we intend them in other cities. But again, it's probably too early for us to determine that. So just to be very transparent about it.
Mira, are you taking the floor? Do I yield the floor to someone else? The floor is yours.
Thank you. Thank you for that question. We really appreciate when we get these types of inquiries. It keeps us honest and it allows us to engage in a dialogue with our members. So we don't pay taxes per se, but we do pay payroll taxes and we do pay Social Security taxes we used to pay them in New York, but now that many of our employees are in Chicago, we don't hit the limit. I think we have 3 employees, now 4, so we're not quite at the point where we need to pay Social Security, but that's something that's coming as well.
Yeah, and just a point of clarification there. My understanding, which could be wrong, of how that works is it's also based on where the recipient is living. So it's often more determined on that rather than where the organization is, though obviously where the organization is often where most of the employees are.
Yeah, of course. And what we do, and I'm on the road a lot, so what we do is where's the primary work office location? We consult with our accountants as well as the accounting firm that does our audit. So they've advised us on the best way to file our taxes appropriately. Thank you.
Thank you very much, Dr. Lane, for your conversation on that issue. McGee, you wanted the floor?
Well, just very briefly following on from Fizan, I think the practicality is exactly as he said it, and I wasn't party to the interviews or appointment of Brendan, but clearly there must have been some discussions as to where he was going to come and work, and if so I would have presumed when I had heard that he was coming to Chicago that is something that the organisation will have to row in behind and accept, certainly for the duration of his initial contract, and that would be the sensible place for the working office to be. Whether there are strategic reasons to have the registered office elsewhere is a matter for people that understand those things better than I do. Thanks.
Thank you, McGee. The floor is yours.
Yes, I think one of the important points to come out yesterday was the necessity of having a budget, and a budget that is pre-approved by the board. So that's something that will need to come up. The second thing we talked about was capturing the value of all of the volunteer hours that come from all the members of the board. Fazan has said, and it's quite true, that he's donated countless hours. Those have not been captured. We haven't budgeted for those. Those don't have a dollar amount, but they do contribute substantially to the value of the organization. And as we put a value on the work of the organization, that pro bono work that we all do, every one of us who's here and every one of us who works on a committee and does other work outside, that actually does have tangible value, and we have not captured it. We've talked about how to capture that, but what the staff can do would be to submit a survey really to all of us, and we could send in the amount of time that we have put in this calendar year. This actually would translate and can translate into a dollar amount, which then would go on our annual report. So I think it's important for the rest of the world to know how much is done really by members of the committee. In financial terms, we can translate it, and there are enough nonprofits in this organization that have experience doing that, that the staff can draw from that experience.
Thank you for your comments, and I know that particular point will be coming up in the next presentation for the Development Committee, but thank you for the input. There being no further requests for the floor for this particular presentation, let me thank Dr. Lane for your presentation on finance and audit and the comments made under 501c3. It's a very, very important issue for the Alliance itself. And in fact, I would also mention, for the sake of transparency as well, my wife who's here, she actually incorporated 2 501c3s and chairs a very successful one in Washington. And I did invite Brendan to sit with us during the course of the day and have a discussion and some advice on, how that should be managed in some form. So I would happily pass the floor back to you for development and resource mobilization, Dr. Lane.
Well, development, the first thing we discussed in the development structure was what you've heard from Catherine. And this is something which is important because I'm not sure in the UK we go down the same route, and perhaps we should. I won't repeat what she said, but I don't think there are any particular tax advantages to reporting volunteer work, but there may well be substantial fundraising benefits. So from the advocacy point of view, it is important. We discussed again the question of a budget. I know I've already reported on that, and I won't repeat what I've already said, except that the budget should, of course, be based on activities and necessary human capital and manpower. We also spent a little time defining what we meant by development, and it transpires that it's not just what the word means, but it's also raising funds, it's building capacity, it's increasing membership. Do we want membership to be a key revenue stream? And how many members are we bringing in, and how many members should we bring in? And that's already been discussed a few minutes ago. We talked about potential models for development. Option one, of course, is increasing membership to provide the main stream of revenue. Option two, to have a structure similar to the American College, which is 20% membership dues and 80% other, a bit like WHO as well for that matter. And whether we should facilitate a surgical summit as a product and additional stream of revenue. We came to no firm conclusions. These were just discussion points to think about. We did discuss the question of corporations and the fact that they're not on a sliding scale. And it was decided, or it was suggested that perhaps they should pay 2 or 3 times the fees because of the income that they generate. Government and corporate funds should go towards programmatic activity and implementation. That was also pointed out. And then we discussed various suggestions towards the end of our time. We thought that we should use more pragmatic implementation science to inspire donors and spark the evolution of a registry. Focus more on our audiences. Who are they and why are we asking for money? And that we've already discussed that elsewhere in this meeting. We've now been in existence for 18 months, and the next year is going to be important because people will start asking, okay, well, now you've got all this money, what are you doing? What have you achieved? We've achieved a lot, but it's a question of getting that message across. We need data to improve and also must decide on a data platform to get industry involved more than they are. It was suggested that perhaps we could look at a grant writing workshop for global surgery work to increase interest and drawing funding to global surgery work. We needed to simplify and break down the development of G4, whether by membership dues, philanthropic and government efforts, or corporation. G4 must be sustainable. There must be enough money in the bank, maybe a year in advance of our activities. We ought to have clarity of core functions, and prioritization is needed for progress. And the current functions that we discussed, that have been discussed elsewhere, advocacy, policy implementation, and resource mobilization. And at the end of these two meetings, one followed the other, we all agreed that we would be prepared to hold online meetings at stated times throughout the year for these committees, because they're so important. And in 3/4 of an hour, you can't discuss everything that really we should be discussing. So those are just the main points of that committee, Mr. Ambassador.
I thank you, Dr. Lane, for your contribution. Any comments or questions for this committee? I thank you again, Dr. Lane, for both committees you have chaired to date. Having said that, ladies and gentlemen, we are running a tad bit behind, but I think we all appreciate the healthy discourse. I'm sorry, go ahead.
I think it would be very useful for members of the G4 to see I suppose from Bob and from Brendan, two budgets. One is what is your core budget, i.e. what is your, if you like, sort of bankable income and absolute core expenditure, so your essential budget, and then your aspirational budget, which is where we would like to go. And if we could see those two next to each other, it would be enormously helpful for membership to be able to support the G4.
I thank you for those comments. I think they're very reasonable, and Brendan and I will look at that. Thank you.
And if I could, if it's possible, Julian, I mean, we're in the process, our accountant has reviewed this year's budget, and we're moving towards an ideal where we could be presenting the budget 6 months to a year in advance. Again, with so many operational changes, new staff, it will vary. But again, I mean, to go over the current budget, I think our core operational costs right now are about $350,000 to $400,000. But the way we've charted out our budget, we'll be operating, I think, around a $700,000 budget in 2016. Aspirationally, we'd like to bring that up to about $1 million, which would allow us to do a little bit more. Again, it's a lean budget for the size of the organization, but I think that's a great idea to work with Brendan to come up with something like what's our vision, but actually what do we need to keep the lights on and to keep services up. Thank you.
Thank you, Mira. The floor is yours, sir.
Yeah, I just want to note what may be obvious, but just for clarity, that we're talking budgets now, but we're operating right now in the initial founding stages of a global organization. And we are doing two things. We're schizophrenic today. We're doing governance, fiduciary board sort of role. And now we're also split into committees which are handling a whole array of activities which could be called operational. And the day will come when we cease to do this. We don't plan where the office should be located. I listened to the discussion about Global Center, where it should be located. I've worked with organizations that have spent years trying to get the right location. It's a big issue. The day will come when we will not be handling such details at this table. We should be handling just the pure governance issues, strategic, major policy, global issues. So when we talk budgets, can we just, in our heads, just be clear that the budget we need to start working toward will be one in which most of these functions become part of Brendan's management responsibility?
Fully supported and agreed. Sir, the floor is yours.
At the meeting yesterday, I thought it was very good discussion about the fundraising activities. However, one of the concerns I had was I felt there was not enough emphasis in terms of what is the money being raised for. It was not a sufficient discussion at that session regarding what are we really trying to do and how we know we've done it. And how does that tie into the fundraising efforts? I got the sense that there was an overwhelming interest in raising resources, but the resources weren't necessarily connected to very specific actions as a whole. And I think that And the good faith of me is I know that that is something that's intended and that people are working on, but I just wanted to highlight that.
Sure, thank you. And if I could just wrap this last part up before we move to the other item, I think the point made by the penultimate speaker, your intervention is spot on. And at the end of the day, I think we need to also be, from a satellite point of view, appreciate the fact that at a board of directors level, we have the responsibility for policy formulation. At a permanent council level, we have the responsibility for policy implementation. At a Brendan and executive committee level, they have the responsibility for policy execution. And I think what needs to come forward in time is a strat plan tied in very carefully that is linked very, very articulately with a work plan that is driven by a program budget that would have the two elements mentioned earlier, an operational budget and an aspirational budget to tie into all the activities we would have approved at the level of a board of directors. And I think this discussion was had, and I think functionally, when the executive committee comes up with those plans as well as the budget, it ought to be approved by the chair of the Finance and Auditing Committee to be brought to the attention of the Permanent Council and for final ratification at the level of the Board of the Directors. And I think that's the process we hope to follow in time to come. So again, thank you all for your contributions. We are now at agenda item number 3.1, and we would commence this item, which is recap of the global consultative process and distribution, of working group assignments, and we will commence this session with a G4 consultative process video, and then Mira Mahis will take the floor subsequently. May we have the video, please? Thank you.
The world is facing a crisis. 5 billion people do not have access to safe, affordable surgical care and anesthesia. Each year, 18.6 million people die from surgical conditions that go untreated. When there is no access to surgical care, simple minor injuries can become life-threatening, and temporary disabilities can become permanent. In response to this crisis, leading organizations from around the world have come together to form the Global Alliance for Surgical, Obstetric, Trauma, and Anesthesia Care, known as the G4 Alliance. Launched in May 2015, the G4 Alliance comprises leading organizations with operations in over 140 countries working together in a coordinated fashion to improve health care for neglected surgical patients around the globe. The G4 Alliance provides a platform for member organizations to advocate with a united voice for greater prioritization of surgical, obstetric, trauma, and anesthesia care as part of the global health and development agenda. The Alliance relies on a collaborative strategy based upon 3 core pillars: advocacy, policy implementation, and resource mobilization. The G4 Alliance Global Consultative Process. To develop an effective and coordinated advocacy, policy implementation, and resource mobilization strategy, consensus must first be achieved among member organizations as to internal priorities. Through the G4 Alliance Global Consultative Process, input is being collected from member organizations and stakeholders around the world. Our goal is to develop a global action plan and accountability framework to ensure that surgical care is prioritized. This information will contribute to the development of a common platform to guide our collective civil society response, as well as helping move our community towards development of a global accountability framework to support the implementation of the recently passed WHO resolution on surgical care and anesthesia. The initial slate of key framework elements prioritized by G4 member organizations includes key messages. In order to define a consistent voice and compelling messaging, key messages need to be agreed upon so that they can be used internally among G4 Alliance organizations, and then externally to help influence policymakers, funders, and the general public. Country-level goals, targets, and metrics. To ensure we are all measuring the progress of surgical system strengthening in a uniform way, consensus around national goals, targets, and metrics is needed. Building political support for a global surgery accountability framework will also be necessary to achieve large-scale health systems change. International standards and guidelines for essential surgical care. The G4 Alliance seeks to foster a common expectation of minimum standards and guidelines that will define what services and resources are needed to provide surgical care safely and efficiently at first referral district hospitals and across different levels of the health system. Development of a data platform to capture operative case data. A data platform is needed to capture surgical volume and safety data at the country level. An approach which focuses on operative case logs will allow for safety, provider distribution, and regional capacity data to be collected. To facilitate this process, the G4 Alliance is building consensus around the minimum data elements necessary to establish this platform. This will enable the global community to capture data that can be used to track surgical case volumes globally based on real-time operative case data, allowing us to move away from modeling data and improving the way we measure surgical capacity. Building a data platform to track health workforce training and partnerships. Building a data platform to track health workforce training and partnerships is essential to establish a better understanding of the current workforce and to support greater transparency regarding partnerships and training programs that are currently in place. This will improve the efficiency of our efforts in strengthening the surgical care workforce and will allow us to better understand where gaps still remain. Together, these key elements are intended to inform the G4 Alliance's strategic plan. Through the consultative process, the G4 Alliance seeks to support the development of coordinated solutions that will foster collaboration within the global development community and with international organizations, such as the WHO and UN. We invite you to join the G4 Alliance's global consultative process by attending a regional meeting, participating in the G4 Alliance's webinars, submitting your feedback online, and encouraging your organization to become a member of the G4 Alliance. We welcome your voice and your expertise in addressing the needs of neglected surgical patients around the world. For further details about the consultative process and the G4 Alliance, please visit g4alliance.org.
Thank you. Mira, the floor is yours.
Thank you very much, Ambassador. Well, we're really excited today because what we're going to be talking about is how we can align our network behind a common advocacy framework and a common accountability framework. And what I'll be speaking to you about today is how other movements have established these types of frameworks and have established a unifying goal and target. And I think if there's one thing that we can do as an alliance, this would be something that we can put into motion very soon, and it's something that could make a lot of difference historically moving forward. So we did view the video, and thank you for screening that. I think many of you are already familiar with the key framework elements, and we'll be breaking out into working groups later this morning and hearing presentations from the groups. But really, the consultative process, and we've mentioned it before, it was important for us to have it was important for us to have a process here. Let me see if I've got to have a consultative process that would allow us to first consult with our member organizations, and second, engage with different stakeholders on the ground regionally to seek input regarding are we focusing on the right things? What are the key challenges faced within regional context with regard to provision of safe, effective, cost-effective surgical care? What are the workforce issues? Really, what should we be advocating upon? What should we be including in our global action plan, both focusing on advocacy and influencing or pushing for policy attention and action? Many of you will be familiar with our key framework elements, and if you are not, and I apologize, I think our graphic went missing, but what we can do is if you refer to your board packet, section 5, There's a section 5, page 95. You'll have a breakdown of our key framework elements and the objectives of each committee, and that may be a good reference for all of us as we engage in this discussion. Now, again, these framework elements are really intended to help us develop our global action plan and are designed as an initial slate. They're not by in no means our conclusive or final list of areas of focus. With that being said, how can we learn from other global health movements? What have other organizations done in the past? What elements have been in place for other public health movements to be successful in advocating for specific action around targets? So what we'll do, and I think we've talked about this movement before, but as one example, we'll take a look at the NCD Alliance. And in recent memory, this is a network that has been quite successful in prioritizing specific actionable targets, and that has had global country-level support around what they've established. To give you a little bit of background, so the NCD Alliance, for many of you are probably familiar with it, but it was founded, I believe in 2009, with the intention of prioritizing 4 major demands, but also their focus is on putting non-communicable diseases on the global agenda. At the 62nd World Health Assembly in 2009, a number of things happened. So the founding organizations held a meeting with 150 high-level representatives to talk about the importance in the issue of non-communicable diseases, to shift the focus from perhaps chronic condition, or rather perhaps infectious disease to chronic conditions, which up until that point had not been receiving the attention they likely deserved. At this Assembly of Representatives, this was the first joint NCD Alliance meeting, and at this meeting a public call was issued, first of all, for a high-level UN summit on non-communicable diseases. Secondly, there was a call for the inclusion of NCDs in the Millennium Development Goals, and subsequently now the Sustainable Development Goals, which were introduced last year. And thirdly, there was a push for access to affordable, quality, essential medicines and technologies for NCDs. This language is important because it's currently reflected in the current Sustainable Development Goals and targets. So again, this shows the power of language and of advocacy. And then finally, integration of NCDs into health systems, particularly primary health care. And I'll take you back just one slide. You know, the strategy that they've adopted was really to have a number of countries and governments align around these 4 specific goals. And they've activated their network both through the NCD Alliance on a global level, but also through regional networks at the country level. And this is perhaps a model that this is a model that we have been considering and something that I think will strengthen our efforts overall. And what is the policy context for the G4 Alliance? So given the NCD model, and we'll touch base more on their specific targets that were established. Within our context, we do have a WHO resolution, and you've heard about it extensively throughout this meeting. But this resolution does urge member states to collect and compile data on number, type, and indicators of surgical procedures performed, referrals, perioperative mortality, and a number of other data points. So I think we really have to draw on what member states have committed to. You know, what is the additional policy context? Well, there is prioritization from the World Bank, from the WHO, from USAID, and other global organizations, multilateral organizations. At the Measurement and Accountability post-2015 conference, there was a statement made to say that public health and clinical care cannot be delivered safely with high quality in a cost-effective manner without seamless, sustainable, and secure data and information exchanges at all levels of the health system. So that means facility level, national data aggregation, and then review of the data globally. When we look at the NCD Alliance, they're fairly well known for their 25% reduction target. So 2025 goal of reducing premature mortality by 25%. With surgery, it's a little bit different because to collect data on 25% reduction in deaths from surgical disease, it's something that we've discussed, but perhaps it's not the best target. And Dr. Hyder is going to speak more about the specific target that the specific unifying target that we've recommended. But let's take a look at how they got there. So the NCD Alliance campaign advocated for inclusion of 9 global targets and 25 indicators. At our board meeting last year, we had their former chair, Mr. Kerry Adams, speak to us regarding the development of this framework and these targets, and it was a process that involved meetings with multiple country representatives, members of state, advocacy organizations, NGOs, and really it was a negotiation process to decide what they would prioritize under this 25% reduction goal. What did they end up with? Well, their targets are slightly different than what we would focus on, but some examples: 10% reduction in harmful use of alcohol, obesity and diet. An increase in decrease in physical inactivity by 10%, or rather an increase by 10% of activity. Again, there are different metrics than we'd be focusing on, but again, it gives you an idea of what was prioritized. You'll probably even see at the World Health Assembly this year a huge focus on nutrition. For instance, 30% reduction in salt intake. I mean, you are really seeing these targets permeating through the discussions that are going to be happening at the WHA and at within regional contexts, for instance, PAHO, EMRO, et cetera. This is simply intended as a model. So how did they do it? Well, the NCD Alliance received support from the WHO for this NCD Global Monitoring Framework, their GMF, following a political declaration on NCDs that was adopted by the UN General Assembly in 2011. Additionally, member states formally adopted this global monitoring framework as part of an omnibus resolution at the 66th World Health Assembly in May of 2013. Now, this process didn't happen overnight. So as we mentioned, the NCD Alliance was launched in 2009, and at this meeting, that's when they made their initial call for a high-level summit at the UN. In that same year, CARICOM countries, so countries from the Caribbean region, came together to issue a joint statement in support of a UNGA special session on non-communicable diseases and a call for inclusion of NCDs as part of monitoring and evaluation frameworks for the Millennium Development Goals. Additionally, in that same year, at the Commonwealth Heads of State meeting, 54 countries came together to issue a statement calling for a UN high-level summit on NCDs. So this was several years before the actual UN, well, rather, their process was actually quite short. So from 2009 to 2011, I think everyone was so impressed by how quickly the process went along. And from speaking with Mr. Kerry Adams, even the board itself was quite shocked at how quickly the process went. But it is a great example of how, when a community bands together, there can be fast movement around their targets. In the year following 2009, there was a UN General Assembly vote in favor of a resolution, and the resolution was 65/238, and this resolution called for a UN summit on NCDs in September of 2011, so the following year. And at this UN, or rather following this resolution, there were a number of other events, including a UN MDG review summit that called again for the inclusion of NCDs. And then finally, in December, the UN General Assembly unanimously adopted a modalities resolution outlining the scope, format, and organization of this NCD summit, which happened in 2011. This is not to say this is the only way for us to get surgical care prioritized as part of multilateral organizations working through the UN, but it is one example of how we can encourage governments to adopt an accountability framework that would really put the WHO resolution into action. So again, these are some of the voluntary targets that we've reviewed before, framed differently under the WHO framework, same targets. And as we mentioned, subsequently there was an omnibus resolution at the WHO. These are some of the preliminary documents leading up to it. So comprehensive global monitoring framework and targets for the prevention and control of non-communicable diseases. We really need to elevate surgical care to the next level. One resolution may not be enough. We want to encourage governments to sign on and sign on publicly. I apologize, I'm having some clicker challenges. And this simply gives a deeper dive into some of the specific indicators, the 25 indicators that are associated with the targets. So for instance, indicators to monitor trends and assess progress made in the implementation strategies and plans on non-communicable diseases, focusing on morbidity and mortality and risk factors. I'm happy to share this documentation and send you a link if you're interested, but we really think this is an area where our G4 Alliance network can provide guidance. We have experts at the table. It's not too soon to start thinking about what this framework would look like for global surgery. I think we've overused the batteries. Again, more background info, but we can share this later. And all this is to say that, and I'll hand it over to Dr. Hyder in a moment, at our last board meeting, we did present a global unifying target and proposed it, and it was voted upon. That's just one step. If we're able to frame this target and other targets if needed under a global accountability framework with specific indicators and specific goals that are time-bound, that are tied in with a cost assessment or a budget, I think we're actually going to get closer to implementation, whereas if we just have a broad declaration without any specificity, we risk seeing the resolution fall into that 80% category of not being implemented. So again, G4 Alliance and our member organizations are well positioned to advocate for development of this framework, focusing on country level goals, targets, and here we have metrics, but again, indicators moving forward. Thank you very much, and I'd love to hand it back over to Ambassador, our chair.
Thank you very much, Mira. I would happily pass the floor to Dr. Hyder of Harvard for unifying global targets, explanation of the process, and requests to working groups to determine how to implement. The floor is yours, sir.
Thank you very much, Ambassador, and good morning, everybody. Before I begin explaining how this process worked, I want to take a moment to just talk about what's at stake here. I mean, I know we're all here to advocate for the 5 billion patients who don't have safe surgical care, but let me take you for a minute and introduce you to a patient. This patient's name is Taimur, and Taimur lives in Pakistan. He's my distant cousin. I remember running around with Taimur. I used to run track, believe it or not, and Taimur was always faster than me. He was a little bit taller than me, and I could never beat him. Money was not the issue for Taimur. He was from what you would call a middle-class family. His dad worked at a printing press. His dad had educated himself in the United States. The family had a nice, modest home. They had 2 cars. And Taimur went to a very good university and got an MBA. One day when Taimur was driving home from his new job, he got into a car crash. The car crash was significant. He broke his femur, and he had a small subdural hemorrhage. Now, he was taken to a government hospital, and to make a long story short, he didn't receive the best possible care. He did get an operation for his open fracture, but I met him maybe 2 years ago, and he still walks with a terribly pronounced limp. He lost his job. The family lost their cars, paying for all his care. And he never ended up doing all the things that are common, right? He never ended up getting married because he always had these medical problems. Not that that's the most important thing, but just making a point, he didn't ever progress the way he probably would have had he not had this terrible crash. And that's just an example that it's not, these 5 billion people we're talking about, they're not people that we can't relate to, that's somebody who never went to college, or like everybody here probably has. These are people who could be anybody. And that's why what we're talking about is not just access to care, but truly safe and proper care that will help them get the best possible outcome, just like if we had walked out of here today and get in a crash right across the street. Now, I wanted to just start with that, just to give an example of what's at stake. When we talk about these big numbers and so on, we kind of sometimes forget about what we're dealing with. And when, can I have my next slide, please? And then when we were tasked with coming up with goals, targets, and indicators, there was a reason why they were all very different. The goal had to be what our overall goal is for the G4. And that's pretty much set. The goal is to provide safe surgical, obstetric, trauma, and anesthetic care to the entire world, to everyone. But then we needed to have some sort of target. And the target would be a time-bound target that we all thought was achievable. And then how are we going to measure those targets? For that, we needed indicators. And this committee was tasked with developing indicators and coming up with a target. Now, the first thing the committee did, and I must give a lot of credit to all the committee members. Some of them are here. My co-chair, Dr. Samad, is sitting right next to me. The first thing the committee did in a very deliberative fashion is to review what indicators were already out there. So we looked at the DCP, we looked at the WHO, and of course we looked at the Lancet Commission indicators which had just come out. In fact, 2 or 3 Lancet commissioners were part of the early meetings. And we all agreed that the 6 main Lancet Commission indicators should be part of our core set of indicators. In fact, the first discussion was, aren't these indicators just great? Let's just go with these. But then the discussion was that we're about surgery, anesthesia, trauma, and obstetric care. And perhaps we can add to these indicators to ensure that all of our 4 constituencies are well represented. And so through a very deliberative consultative process, which lasted for about a year, was done at 3 different countries, multiple webinars, and these webinars weren't just where somebody was just talking. These webinars had 70, 80, in some cases 120 people logged on and giving comments. We came up with these proposed indicators. And the indicators focus on both access, quality, and then, of course, very importantly, financial risk protection. And you'll note that these indicators, there are 15 of them, they include the 6 Lancet Commission indicators. And they add to that things which are specific to certain diseases. For example, for trauma care, inpatient trauma mortality rate. For obstetrics, maternal mortality ratio. For anesthesia, POMR, or perioperative mortality rate on operative day. So those are just 3 examples of specific indicators that were added to the Lancet Commission indicators so that we would be able to represent all of the people at this table. We also came up with a scheme of how subspecialty indicators could be created. So for an organization that's, for example, focused on cleft lip and palate, how would they come up with indicators, or how would there be some indicators focused on a subspecialty issue? And here's an example of how that would work. You know, the population level incidence, the DALYs associated with that, and then the quality and financial protection. So this is kind of how, after an entire year, the committee worked very hard to come up with these indicators. Now, after that, we realized that we need to have a unifying global target. And this was in response to the need to have something that would inspire change and unite the community. And remember, this is a specific time-bound actionable objective that optimizes the response of our alliance and the stakeholders. Now remember, this global target is different from a goal. The goal is that every single person, every person like Temur, wherever they are in the world, can have access to care. But where are we going to be 5 years from now, and where are we going to be 15 years from now? That's the target. And we came up with a target that would have these criteria. First, it had to be meaningful for on-the-ground change. It had to be compelling. It had to be succinct, right? You heard about the NCD Alliance 25 by 25. It had to be something that was simple to understand. And it had to be in alignment with the global health funding priorities. It had to be aligned to something that was happening. So we needed to pick a date or a time period that was already bound and something was happening at that time period. And so we presented and all of you know what it is. It's 80% of the world to have safe surgical care by 2030. At our last meeting in Blantyre, there was a lot of debate. So for some of you were there, of course, but for not everybody, for everybody else, there was a significant amount of debate. There were working groups. We went back and forth to come up with what we should do. There was a lot of changing to the wording, And finally, we came up with that one, and these were the pros and cons that we thought about when we came up with that. It was passed with a vote of 20-1. There was one colleague of ours who felt that it should have gone even more, and so she chose to not cast a vote from her organization, but it was a 20-1, and these are the pros and cons. Most importantly, many people thought that was a practical goal that all can rally around. So I'll just stop at this point. This is the proposed target, safe surgical care for 80% of the world by 2030. As Fizan mentioned yesterday, there has been a manuscript written to explain this whole process and propose this target. The manuscript will hopefully will set it out. Our plan was to have it all published before this meeting, and it was sent to almost all of you or many people who are here. 70 plus people have seen the manuscript and have given comments on it, and we really do appreciate that. It made it much better than it was, and we're hoping to get that out in the press, but we really wanted to present it to everybody here before it gets completely finalized and printed. So with that, thank you very much, Ambassador, and I yield the floor.
Thank you very much, Dr. Hyder, as well as Mira, for your two presentations. Colleagues, I'm sure the last two presentations would have incentivized quite a bit of conversation, but we are running a bit behind time, and we have a scheduled panel session for 11 a.m. What I could respectfully suggest is that we think about the last two presentations and address this during the plenary session under open discussion. I think it's a lot of food for thought. Plus, we have to break out now into groups. Sure, go ahead. I'm yielding the floor to Dr. Abdullah, please.
I want to thank Adil Hyder and Mira for really framing what is a very important and timely discussion around a global action plan, or this is laying the groundwork for a global action plan, and I hope they've given you some perspectives about how it all links together. It's hand in glove in terms of having a target and indicators, and then also how that is going to influence those broader systems, and it's really about systems change is what we're talking about here. I think the request this morning, if you look at our agenda, is that now that you've heard the presentation about the unifying target, I think it's important for us as a board to start the conversation around what we're going to do about this. So if you look at, before the ambassador breaks us out into the working groups, so we know what the 5 framework elements are, but I think with the ambassador's permission, I think that it would be good if each of the working groups, the breakout sessions, also spent 15 minutes or so towards the end of your time to talk about how we can operationalize this unifying target. So yes, you've got your specific ongoing work products you've got to talk about, so spend the majority of the meeting on that. But if I would ask the chairs to spend the last 15 minutes talking about the global unifying target, and then when you come back and do your report backs, we'll be able to get 2 report backs. One about your work products, so that's key messages, surgical standards, operative case platforms, partnerships, but then we'll also be able to get a summary about your group's perspectives on what or how we should operationalize this target. And to be very self-aware, that for us, in terms of as we build consensus in this group, will help frame the conversation probably for future board meetings around the specifics of a global action plan. Because once you have the target, then we've got to make a very specific strategy. It's going to take time. You can't just do it in one meeting. So I think that's the big picture, and that would be the request to the working groups. Thank you, Ambassador.
Thank you. Thank you, Dr. Abdullah, for framing that linkage. I think that's important. Having said that, ladies and gentlemen, we have the Honorable Minister of Health of Libya addressing us at 11. We actually had catered 90 minutes for the breakout session. What we would push it back to is have the Honorable Minister address us at 11:15. So I'm going to ask the chairs of the respective groups listed their key messages and national goals, targets, and indicators. You'll be meeting in the Moscow room, surgical standards in the Amsterdam room, developing platforms to operative caseload log data in the Vienna room, and developing a platform to track partnerships and synergies. You'll be remaining here in the ballroom. You would start now. I'm asking you, please, we don't have a scheduled coffee break anymore. Grab a coffee and go to your respective rooms. And I will ask the chairs if you can kindly operate your groups with discipline and take into account the last comment made by Dr. Abdullah, and return here at 11:10 a.m., please, for us to start promptly at 11:15, and we will make the necessary adjustments to the time frame.
Ambassador, can I have a point of clarification? What about new members who are not part of a group?
Sure.
Can we add them to?
Yes, we can. Next slide.
We are actually going to put up the slides now, and the new members who are here, we have 4 working groups stated in the present slide. This particular slide is working group 1. These are the members to date. I will ask to hold this slide for about 10-15 seconds so you can look for your name and your organization. If you can jump to working group, hold on, right, the second one, standards and guidelines for global surgery. This is the Amsterdam.
It's 1 and 2 together.
1 and 2 together. Goals, indicators, targets. Moscow room, names and organizations. Can you go to group 3, please? Group 3, standards and guidelines for global surgery, Uni Amsterdam room. Again, names and organizations. New members, please take a look and see where you may be interested in. Go to that respective room, and we will then reassign your names there. And we will update it here subsequently. Group 4, developing a platform to track operative caseload. You're in the Vienna room. Again, names and organizations. Group 5, developing a platform to track partnerships and synergies. You remain here in the ballroom. And again, names and organizations. Having said that, enjoy your coffee. Good luck. See you at 11:10. Thank you.
Just to note, everyone, there will be refreshments and snacks laid out at 10:30. So if you need a snack, 10:30 they'll be putting them out.
tap into the expertise we already have in the Alliance. So if there is a network that really allows us to tap into this expertise easily, that is something that everybody valued from the survey as well. Second, there is an endless effort to develop tools and materials by different organizations. It will be a huge disservice if we start again going and developing yet another tool when there are some successful tools already on the ground. So having a repository of those tools and materials that are existing, if we do have access to those, we can always make changes and improve them together. So if any platform or network is available, it should be a platform that gives that kind of opportunity to members to see what is existing and essentially use it. Other trainings, most of us in the Alliance do provide trainings of different forms, starting from just a day orientation to a long-term trainings in surgical anesthesia, trauma, and obstetric care. But it will be also very important for us if we know who is giving what training and where, so that we can really combine any training efforts and, if necessary, do a joint training if we're doing the same thing in the same region. That way we can strengthen the support we provide a particular group. So just knowing what is happening where is a very strong input to our members. Of course, others, all of us are engaged in doing lots of things on a regular basis. So just knowing what is happening in the form of announcement to all members is a great opportunity for us to essentially understand and know what is happening around us. And it seems to us from our discussion, even in small group discussions we were having yesterday, there are a number of things different member organizations want to do. The only thing they don't know is like whether it has been done or whether they can really talk to others in terms of, we really want to expand our work in this direction. So instead of leaving a given member to explore these things by themselves, having a list of those things that a partner member wants to do will actually create a discussion within the members to actually find the solution within, or having a consultative process to come up with a very effective way forward. And of course, making sure that all what we do, from the announcement, the trainings, and the materials that we are all developing, from just having them on a desktop somewhere to somewhere where they can be found in a searchable database, at least within the platform that was created, will again bring the work to visibility. So these were the 6 components that consistently came from our discussion with different members. Now, these are good ideas, but is this really easy to do? Is this feasible to do? What is the best way to go about and doing them was some of the questions. So we didn't want to just simply jump and say, okay, let's do it. But we went ahead and asked a few, maybe Catherine, I'll stop here and maybe you can talk about what we did in terms of, okay, if these are good ideas, what have we seen others doing? What did we learn from what they did?
I'd be happy to. Can you go back a couple of slides to the first bubble? Yeah. I just wanted to add a little bit here for perspective that the way, and this actually adds to some of the complexity of what our debate has been and our dialogue has been, the way that Tigi was just presenting these was in the context of what our members would find valuable. And that was certainly one of the things that we considered was, is this essentially a member benefit, or is it meant to be a larger contribution to easing or improving, access to quality surgical anesthesia, obstetric, trauma care. So that's one important distinction. And as a part of our process, just to go a little bit deeper into what the process was involved in, for those of you who are on the webinar for this was relatively recent. It was gone into more depth there. But just to remind those or to tell those who weren't able to participate in the webinar, or to remind those who were, what we did was we tried to at first understand who are all of the communities that might be able to benefit from this sort of information. And let's try to both understand what their needs are and understand what their usage patterns would be of such a resource if it existed. And so we ended up with, and I don't have the slide, or we don't have the slide, and I don't have it immediately accessible in my memory, but essentially what we said was, okay, clearly one group is members of the G4 Alliance, member organizations, individuals. Another group is somebody at an academic medical center who's involved in global surgery, and they're interested in either establishing a program or have a program and want to partner with others and want to know who their partners are on the ground and want to know what resources, all of the above. Another stakeholder is those surgeons or anesthesiologists or, you know, the surgical workforce within the country, or their Ministry of Health. Those that are delivering care in the country are responsible for the delivery of care. What will they want to know about who's coming into our country? What resources do we have to access? What online tools and data can we create that, in terms of case log stuff, this is meant to not be siloed from all the other working groups. We're talking about a case log database. Is that something that they could get access to and then input their data into? So we tried to look at it across the spectrum and sort of around, you know, around the whole gamut of how this could be best used. And then just as a brief reference, we then went through this little exercise where we created a scenario, case use scenario and a profile of those people, who they were, what they did, why they were using this. We wrote up a little bio of how they would use it, and then went back and cross-referenced it to see what were the things that were common uses, what were the things that really struck us as, you know, God, it seems like everybody needs this. And that's where we came up with these 6 things. They are, as Tigi framed it, they're very common things that you would expect to have access to. But it was nice to be able to vet, you know, how they would be used differently by different groups. So that's one thing. And then, do you want to go to that other slide about the value? Oh, I have it, sorry. So, and that's probably described all there. Oh, this is the last slide, right? So the lessons learned from the field. We talked to a number of people. Marilyn Butler, who's with the Global Pediatric Surgical Network, was a member of our working group, and she's had firsthand experience in trying to create this kind of virtual community that's supported with resources and facilitate communication. In my prior role with the American College of Surgeons and Operation Giving Back, tried to equally, you know, the way I always described it is how can we support this ecosystem? So all of these various connections and synergies and providing information, filling gaps in information, how can you do that? So we had that. We also had a great opportunity to speak with Sonia, Dr. Sonia Sachs, who has been involved in the Million Healthcare Worker, was that what it was called, Million Healthcare Worker
1 million healthcare
program, and what they were looking at community health care workers and trying to map all of them and where they were, and she was very frank about the issues she had with data collection and just understanding a consistency of how data was defined and the politics behind sharing of data and kind of the onerousness of trying to get everyone to input their information. So in any case, there's been a number of efforts to get in different projects to get to this sort of concept of how do we create this great tool where really people can I think what it really comes down to is the maintenance of the data. And how do you incentivize? We had long conversations on how do we incentivize use? How do we both incentivize data sharing and people actually going to having this be a valuable enough platform that's where they go to get their information and their data from other of our partner organizations. And I think that's where we really got, I won't say bogged down, but really it's hard to know with the depth of detail and information and just the development of this platform and the resources that will be required. It's a hard thing to understand. Will this be valued enough to be worth putting in the time that will be required? I think that's the last bullet point there.
So just like a quick summary of like the lessons, and then I'll open it for discussion, right? So one, what we've heard consistently is, yes, it's a great idea, but you won't really get users to have that kind of communication the way you described it. Because we were really going all in, asking members to have this very active interaction, essentially like a Facebook for surgery. So consistently, the message is data collection like this is complex, and you'll be disappointed. One. Two, getting incentive for members to actually have that kind of active engagement is very difficult. So what we thought, and we wanted to open to you, is maybe this is a time for us, especially at this time in the alliance formation, maybe we should give it some time for organic development and scale back a little bit and see what is the most important of the 6 components. Which one will be the most important? We can start probably easily without really taxing the workforce and the resource we currently have. So we talked about the expert, at least what we have currently easily accessible. If we can start with the expert and tag the expert networking using the Alliance website as opposed to creating the platform now, but then have a plan. We actually have a phased approach, phase 1, 2, 3, and lead to a phase 2 or phase 3 where we go into the platform depending on how we evolve. I'll stop here so that I hear, yes,
Tiki and Mathis and the group, I really want to extend my appreciation for really a coherent summary for what has been a discussion for a long time, I know, for many of you, and you've put so much time and energy into this, so I'm very grateful to you for that. But I just wanted to make a few minutes of comments to contextualize this work and in terms of the other working groups, and also moving forward. I think at the end of the plenary session today, we're going to talk about how we can better coordinate amongst groups, so that is beyond just sort of the informal conversations that I'm conveying right now. We want to formalize that structure and engagement as well. But let me just share a couple perspectives. First, I think the point you raised about value proposition for member organizations, individual members and member organizations, is critical, because if there's no value proposition for engagement, people won't engage. So I think the fact that you've looked at this and said, you know what, we should need to take a step back is absolutely the right approach. We've talked about the last board meeting, people may recall, Kathleen, definitely, we had talked about the idea that when you look at clinicaltrials.gov, for example, for all the clinical trials that are being done in the US, they have a two-step approach. Number one, they block any organization that didn't file clinicaltrials.gov at the funding level, because you can't get funding if you don't have yourself registered at clinicaltrials.gov, and then they block it at the publication level. That basically that editors have signed commitments of the major journals that you cannot publish on studies that were not registered. So there's a little bit of a stick and a carrot phenomena. So I'm not saying we should take that punitive option, but I do think it's important that to realize that it is available. We could actually, Walt was here, we could talk with Walt about how this could potentially operationalize. The next question is, so you're doing all this conversation, where is this going to go for a working group from the G4 Alliance perspective? To be very frank, all the working groups, they're really building consensus around the ideas and what the requirements would be of a system like this. And to be we think that the strategy would be, we have enough of a critical mass of organizations that either through pilots, because you're right, we should start up through natural organic operationalization of pilots, this will start taking root and then larger funders will notice, Or you may come up with, you'll keep putting together a proposal that may go directly to a larger funder. So I think the group should keep that in mind. It's not that you're just going to continue to talk about this. The idea is to operationalize this over time. And that's going to take some time. I don't think that this is something that's going to happen immediately. And then just to give you one idea that's come up from another group is the National Surgical Planning Tool. So the idea that how can the G4 Alliance, as a network of organizations all over the world, support national surgical planning? But maybe one thing we could do is develop a registry on the G4 Alliance website where we already did an inventory, but do even more of an inventory in terms of an ongoing, organic, living, breathing inventory where organizations self-identify if they're willing to do national surgical planning in specific countries and they offer specific expertise. So instead of doing the whole space, you just say, you know what, right now the most important current context is national surgical planning, so we'll make a diary of national surgical planning organizations just at the table even. If you just suddenly, we have enough, you're probably covering, no kidding, in this country, in this room, we have 100 countries covered right now. So if we just made a list of the contact information, the discipline-specific expertise, and then basically we could create an interactive website on the G4 Alliance website. You could click on a country and you could say, this is a national surgical planning tool. If you're doing national surgical planning and you need expertise in neurosurgery, these are the groups that are willing to volunteer their time and energy to help you. Or if you're a Ministry of Health. So we don't even, so it's a decentralized approach to supporting national surgical planning. I'm not saying do that, but I'm just giving you that as an example. And with your permission, I'm going to move to, unless it's an immediate comment, I need to move to another group.
Thank you. Thank you very much. Yes.
I would think this is anybody wanting to start a program of training who want to know who members of GUCH would want to know, they're the universities doing international work, who is doing what, where. So we want to encourage everybody to join, basically, so for their own benefit and the country's benefit.
Just a quick comment to that point. So that's in terms of scale, that's a big thing. And we've talked about, should we scale it with just looking at what the members are doing, and part of the realities of that were if it is just input from our member groups, that's something that is probably going to have to be supported by a very small staff to oversee that, and obviously has limited potential. And the bigger project, which would involve a lot more work, but maybe far more attractive to external funders, would be to invite, as you were saying, all of the activities, all of the partners that are working in a particular space. And even though it looks more daunting, it's perhaps more attractive on multiple levels. So these are some of the debates we've been having back and forth. And thanks so much for pointing that out.
I wonder whether a different way of looking at this would be to look at having, from the membership, G4 focal points in country, who could then create space for collecting the top line information and data around activity in that country, possibly with a little bit of resource, but I'm just thinking of an example. We've just opened a partnership office in Uganda, the purpose of which is for us to bring together the 35, 36 or so health partnerships that are working in Uganda to act as a conduit to the Ministry of Health, but also to share information, share good practice and that sort of thing. And that model, I think, is going to work quite well. And it just strikes me that there could be some kind of parallel for G4, that you have some kind of in-country focal point who would be able to bring things together for that country and then perhaps feed into a more central process.
This is from a given partner, just to follow up. So if you go, for example, to Tanzania, there are a number of organizations who work in Tanzania.
Yeah.
So who will be taking that lead role to collect?
Well, I think it would be for someone to volunteer to do
Volunteer
that.
from the group.
Yeah.
And the other possibility, this morning Mira made a comment about how the Non-Communicable Disease Alliance has created regional centers. And that might make a perfect fit for having regional, oversight. I mean, we're not there yet, but as a way to evolve.
Would this not be an ideal opportunity to involve COSEXA, the College of Surgeons, because they have country representatives in each of the 9 countries, and West African College equally have representatives? No. And that would allow them to participate in a...
Absolutely. So those sort of professional societies were one of the scenarios that we looked at, and we tried to look at all those different uses and who would be assets, and yes, so absolutely.
Yeah, it is a very good point that the national societies, surgical societies, and the regional societies are key organizations to help in this process. And to come to a sort of conclusion of what we want to present after our discussion now, I'm really looking forward if other people have other opinions. Are we looking, what will be the practical way forward now? Because there's this idea of a kind of platform that can be really useful if it is interactive, if it is user-generated, if it can cover a lot of different activities, so not only training activities, but also the missions that have been done by societies that go and do not only give trainings, but also do certain operations in a country. Do we want to include it all? Do we make a kind of complete picture that shows up to date on a website, on a kind of big map, what is happening in global surgery worldwide? That would be fantastic. But our discussion was all the time, okay, that we have to continue working on that, but it might be a long-term goal that we have to approach step by step. And what was one of our recommendations to think about is how can we start to show what are the partners, the member organizations that are at this moment active in the G4 Alliance, what do they do? How can they help in this process, and how can they be more visible? So that's why we came to the conclusion, not immediately starting with launching a big new platform, but how can we use the G4 website that is already there to create more synergy and to show what organizations are doing at the moment and how can they help each other. And then who is going to do that and how are we going to do that? That are the main first steps to take.
I'll come to you, Andrew. So I think the discussion is whether we use the platform or the website. The most important, the key element is there should be a regular follow-up, maintenance, and update. So that requires resource. So if we have to commit, then we need to give that as a proposal, as Fizan was asking. We need to clearly give them, this is a good idea, but it needs to come with a certain resource commitment if we want to do it effectively. So we want to hear from all of you.
Yeah, and can I just ask, does anyone think this is not a good idea?
It's a great idea, of course. The question is this a type of activity that G4 wants to get involved in? So I'll put it in context. The World Federation of Neurosurgical Societies, we're undertaking a workforce and capacity mapping project, and we're doing it with WHO. They have a global health observatory. They have technical expertise to map all these things, gather data. So there's certainly a need to have a platform like this for look for synergies and coordination. But how can we work with WHO in something like this? Because we're not a data collecting or platform for this kind of, that's not our expertise. Maybe some of us are, but for WFNS, we have not that expertise, so we're partnering. And they'll put our data on the Global Health Observatory. So I'm just raising as it a possibility to work with them.
You bring up a really good distinction, And I don't think that anyone in our working group envisioned that the G4 would be collecting the data, that it would rather be a representation of data that existed. So we would have data, whether RSS feeds to existing updatable resources or integration with WHO or other COSEXA data or whatever, but that we could link to all of that rather than necessarily doing the collection itself. If our member groups might be doing some of the collection, we were represented.
Andrew,
Yeah, I think just thinking about the users of the information, these are more likely to be people, they're less likely to be people who are looking for things on a global scale, much more likely to be looking for things on a local, at the local level. So I think that's where it's important to start, and it's about incentivizing not just the collection of data, but the use of it as well. And it's about people needing to understand that there is a good reason for looking at the database, whatever you want to call it, before you start working in Tanzania or before you start working in Ethiopia or whatever, to get a flavour of what's happening. And the other thing I would say also is, can we talk about the surgical workforce rather than just surgeons and anaesthesiologists and so on, the people that go to make up that workforce, like biomedical engineering and so on.
Thank you, Andrew. So we have 10 minutes, so unless you have other questions, we've been asked to discuss about that target as well. Do you mind if we can take 5 minutes, then we will summarize our discussion and have a consensus on what we present after that. But for what was discussed by the goals and targets, the 80% having safe and, what's the target, Dennis? It's not a test.
By 2030.
Yeah, 80% by 2030. Is there any concern to give that kind of support to the target from our team? Yes.
What we're doing is very related to the target. Basically, you've got to coordinate your activities to get the training to develop the 80% coverage. So this is really part and parcel of it.
And presumably you could relate it to the Sustainable Development Goals, particularly as they're connected to surgery.
Final thoughts, questions?
I think one of the concerns was, is anyone opposed to it or would feel uncomfortable using it from their own organization's perspective, sort of, having it either being affiliated with that goal or using it as a frame of reference for how you talk about your work?
Well, I've been in some situations the countries don't want you to know what other NGOs are working with, so they can get everything from each one they can possibly get. We're trying to avoid that by this effort. I was in one country starting a teaching program. Next thing I know, a group from the Netherlands came in. I didn't know they were coming in, and took over all the operating rooms. Yeah, okay. I'll keep my mouth shut.
You're talking. So you're talking about the 80% by 2030. So what percent? So the billions that we say have a lack of access to surgical care. What percentage is that right now?
Of the world?
Yep.
It's close to 70%, I believe.
So we're going to go from a negative 70% deficit to a positive 80% in 14 years. So I guess the question is that a realistic goal?
Well, yes. I mean, that is absolutely.
It's lofty and it's beautiful
Right.
and it's ideal. Is it attainable? And I mean, that sounds like a big number to me. We're not even starting at zero.
Yeah, so it'd be going from like 5 billion without to 1 billion without. It's about the reduction, maybe a little more than a billion.
Yeah, so in resource, at least according to the Lancet, in resource-limited settings, it is less than 20% who do have access to safe and quality surgical care. So the idea is to get to 80% to align with most of the Sustainable Development Goals. And the Lancet did actually a projection with some of the adoption of the decent progress Mongolia has shown or Mexico has shown, that many countries can get there. If there is a concerted effort with, for example, the workforce development, because that is one important challenge we have, regardless of whether it's a surgical intervention or other intervention. So there seems to be all the other groups are geared towards that 80%. So if they are going towards 80%, can we tap into what others are doing? So this is not going to be only the G4's effort or the G4 members' effort, but other communities' efforts are going towards that direction. So why don't we piggyback on that and make sure that that message is consistent? That's the kind of discussion we had in Malawi. So, but you're right, it is a very daunting way forward.
So what were the goals for, let's say, AIDS, and let's think back 20 years. Let's think PEPFAR. What were those goals? Were they as lofty? Okay. Do we have numbers? Because I mean, obviously, we're chipping away at that beautifully.
Yeah, it's for currently global AIDS has AIDS effort has a 90-90-90 goal. So, and the discussion is about AIDS-free. So we're not saying like no, everybody gets surgical at least, but having 80%. There was, when Haider was talking about that one dissent voice was 80% is not enough. People are dying. So it seems to be like the 80% is seen as a bottom line, actually. So it's a good question.
It is, yeah.
80% by 2030, that's 14 years from now. Is there some kind of, is there benefit to have a goal that shows progress toward that in an interim basis, or every 5 years or something?
It is true. You can add in, but I think the goals, targets, and that group is looking at, that is the message, but what are the matrices that really tell us like every year we're making progress? So there are some things being done, how we're translating that on a yearly basis. So there will definitely be some progress goalposts that we need to look at.
I think that would be part of our annual report, and a way to something to measure against. And I mean, as you know, and as Dennis referenced earlier, the 14 years from now being 2030, and the deadline for the Sustainable Development Goals is the why that was chosen. But yeah, absolutely, we would need to perhaps put together big white papers at 5 and 10 years showing what we've done or something.
Great. So we have, it looks like, yeah, Dennis.
If you think that 80% is a lofty and stretched goal, you should look at the monetary value of that 80% that the Lansing Commission reported on. I mean, there's so many knots in it, I can't even pronounce it. I mean, it's a vast amount of money that's required to achieve the 80%. Am I not right? It's a huge amount of money. Investment.
I think the number is $350 billion. $350 billion. But there's a return on investment of $12 trillion.
So it looks like we have 3 minutes. Yes, you have last word.
I'm an observer, so can I make an observation? Is it okay? First of all, to give an overview who is working where and doing what, Ebolina already started with that on the map she showed, so I think we can hack into that to be quicker. And the thing, Walter Johnson was talking, he's alone. So if we want to progress in surgery going to 80%, we need to help him as well with what indicators we want, what kind of data collection. And there's already a lot of input from the WHO on health systems, health workforce, health financing, but these are all things that overlap in our indicators. So we might want to make a suggestion on that to him to help him go forward as well.
Thank you. I think those are active discussions happening with Walter and others in terms of partnership. So just for always, like when we have interesting discussions, the timing is not enough. Just to make sure that we've captured the recommendation as we move forward. It is a great idea to have this, but if maybe we can start with what we have based on the website, have a dedicated resource, write a proposal to start with at least expert and networking and some of the basics, and have a stepwise progress towards a full-blown platform that really asks members to have to actively input data, as opposed to starting with the platform up front.
Can we get some impression on I thought that Fazan's suggestion was really an interesting way to scale it or to do it as a pilot. And if we are asked to work with a particular country around national surgical planning to try to populate a country with all of the partners that exist there as a first step into this to see if it's useful, and then to see, you know, we can replicate that, and then we can make the case to a funder or something to say, let's scale this so that all this information is always available.
Splendid idea, and I think we've got Dr. Mikasa speaking to us about the Zambia. The Zambia one would be absolutely ideal.
I just want to point out, if a country wants to start a national surgical plan or it wants technical advice, they would not come to G4. They would go to WHO.
Yeah.
So we must take that into consideration. I think we should take a very supporting role, but we have to be careful that we edge ourselves in between, elbow ourselves in between this government and WHO.
With that question.
Good. Any?
You have to remember WHO and G's has only 1 or 2 staff members, so they could depend upon G4 to help them out.
Yeah. So it's going to be, it's going to be collaborative. I think it's just working with Walt and others. You're right. I think every time a national government asks for support, we're saying whoever is giving the support, we chime in and see if this platform can work to a given country as a pilot, and then either expand it or change it depending on the lessons. So I think what we're concerned, you can feel like our concern is we didn't really want to go, we had this great idea and excitement to have the platform up and running in the next 6 months. That was the plan. But as we talk to people, it's becoming very clear to us that it is a very difficult endeavor. So maybe we can scale back, see one, improving the utility of our website, but probably plug in a proposal to have this pilot as part of the national plan, learn from it, and then make a decision moving forward.
Quick comment. I find the board member profiles in this booklet highly helpful because it really goes into detail about what the organizations are doing, and if we can expand on that, even a link to the websites on the G4 website, and every organization has a website.
Can I ask a question? Matthias has been trying to push the button.
This is exactly what I think that is the way forward. So we have a kind of pilot for this integrated, beautiful platform, and we can think about it, how we collaborate with, for example, the WHO, how we can do that. And on the other side, in the meantime, we can work on strengthen our synergy. And
our own network.
Our own network, the synergy of the organization. And that's the first thing, and exactly the things you mentioned are really important. So we have been discussing like weekly newsletters about what are the member organizations doing. Somebody's really looking at, okay, this organization is having a meeting, or this one, people from this organization have published an important paper, and that you have a weekly update, what's happening in global surgery, and to start to make it possible, to make it sustainable and also achievable, because if you want to do it for everything that happens in the whole world, it's quite difficult. But start with what's happening within our organization, because that's the idea of an alliance. We are as strong as our member organization, so that's something that's really realistic to start with. And we have been working on it, and Dana has made a beautiful start, but I think the first thing to do is to reinforce and to go further with this. So I really appreciate your comment. Thank you.
And this would justify engaging with the G4 and retaining membership, because the most powerful thing are all the NGOs in this room, and they have to start working together. It's absolutely vital. It would justify membership.
Yeah, so that was when we were first starting about this, talking about, you know, what is of value to the members, and then what is of value in the bigger sense. We understand and fully recognize that there are unmet needs of the members right now around collaboration and synergies and just networking. And so just a quick question to bounce off of everyone. Is there a feeling that there should be a member side to the website so that this wouldn't be public? There'd be a space for us to just interact among ourselves that wasn't public. What's the feeling on that? Because this is really part of the communications things, but it's another side to this working group. We were talking about having a member side and then a public side. So
So we have two.
And it would be good to demonstrate that some organisations are working together as a result of being brought together in this coalition. And you could put up some examples. Yeah, definitely.
Great. Good. Any final questions? Otherwise, I know Tom has been writing all the recommendations. What we will do is, on this slides, we make sure that the recommendations are included. So we make that presentation after the panel. Good? Great.
And yeah, I mean, going forward, having this richness of input for this working group, we've had a rather small working group, so we would welcome all of your input.
Yeah. Is there anyone who wants to be active vice chair of the working group? Yeah, because I think the more people represented, the better. Sometimes when we try to discuss something, he's in the OR, I'm somewhere on crossing the Atlantic, and Kathleen is traveling in between. So we drop those discussions. So, you know, the more we at least interact as a working group, the better we can really influence that.
Yeah, well, I'm going to add everyone's name.
Yes, great. Yes, last.
Okay.
Yes, please, go ahead.
Just have a quick comment. Yesterday I sat in on the membership committee meeting, and it sounds like the member-facing strategy that you're coming up with here and the recommendations should, I guess, be synchronized with what the membership committee is doing. One of the, I guess, big objectives that came out of that was focusing on retention of current members as being a really important thing to do. And so I think even just demonstrating progress in adding value for current members will help with that retention. So synchronization would be important.
Because Dennis made this
Yeah,
point,
yeah.
I think we should focus on taking care of our members.
I had a thought of organising an event at the College of Surgeons in the East Central and South African meeting in Mombasa in Kenya in December, where the NGOs that are connected with surgery might want to come together for a one-day meeting in advance of the clinical discussions. So I was going to put that idea to everyone so we can share ideas and opportunities, and out of it will come hopefully some work streams that we can work on together. Just a thought, an idea.
Much everyone. If you haven't had your coffee, please feel free to get your coffee. And let's write it down.
Ladies and gentlemen, may I please ask that you take your seats? We will be beginning the session within 1 minute, please. Thank you. Colleagues, once again, thank you very much for more or less returning punctually to the table so we can start item 5 on our agenda, which is the next steps for supporting the World Health Assembly's Resolution 68.15, 68.15. And it's my absolute pleasure to warmly welcome our two guests who will be joining us for this panel. We have to my right, to my immediate right, Dr. Rita L. Oakley, who is the Distinguished and Honorable Minister of Health for Libya. Dr. L. Oakley has been active in the health ministry since early 2011, when he was named head of international cooperation. He has also served as Libya's representative at the World Health Organization, where he worked on issues of global health, human rights, and international humanitarian law. I also wish to very warmly welcome to my immediate left Dr. Emmanuel Makassa, who is Counselor of Health for the Permanent Mission of the Republic of Zambia. Dr. Makassa is a member of the G4's Honorary Council and was very much instrumental in supporting the WHO surgery and anesthesia resolution and inclusion of surgical indicators as part of the WHO's Core 100 Health Indicators list. Dr. Makassa, I thank you very much for your service and your contribution to the G4 Alliance, and both you gentlemen for doing the work that you do, and you do as international diplomats, really, in bringing this issue to the forefront. And it's a warm welcome I bring to you on behalf of the G4 Alliance. Colleagues, at this point, I would happily hand the floor over to Dr. Fizan Abdullah, who would actually be moderating this session. Dr. Abdullah, it's with pleasure. I give you the floor, sir.
Thank you, Ambassador. It's such an incredible privilege for me to moderate this session with really what I would say are the top 3 diplomats in the world who are spearheading surgery. And I really have to say that it's the first time that the 3 of them have been together. So for me, it's a very emotional moment, and I'm so thankful to each of them for what they've done. I think the story, I think many of you know, but I'm just going to briefly outline it, is Ambassador Parson, well ahead of the 2013 meeting, has been working with the surgery community, and as was mentioned in the presentation yesterday, his office was instrumental in contacting 150 governments through diplomatic channels in support of the resolution that, to his left, Dr. Emmanuel Makassa proposed. And the Dr. Emmanuel Makassa was also there in Trinidad in 2013, and I think Mira told that origin story about how he got up in the meeting and said the time has come for us to have a surgery resolution. And many people had said it before, but Emmanuel achieved this. So this was an extraordinary moment in the history of our community that we were able to make progress. And really then Dr. Al Oakley, as a Minister of Health, really at the first time at a Minister of Health level, has been engaging with the Alliance. He was almost the entire board meeting. He was with us in Malawi. He flew in from Libya to Malawi just for the G4 Alliance board meeting. And we were incredibly thankful, and his advice and insight has really helped define the strategic plan of the G4 Alliance moving forward. So to have three of them here in the same place at the same time is extraordinary. I think we should give them a round of applause for all that they've accomplished. So we've brought them here for a really, perhaps one of the most important discussions that will impact the near and long-term planning and strategic plan of the Alliance. And this conversation began in the anteroom out there, and I'm so excited to share some of the conversation with you with having them both here. So first, I'll ask Emmanuel Makassa. Emmanuel, if you could give us, from your perspectives, a very brief comment about the resolution which you championed and pioneered. And I know that you also have been working with the government of Zambia, and you are, of course, in the government of Zambia, but you've been pushing the government of Zambia in terms of the remaining infrastructure around national surgical planning. If you could make a comment about that, and also the new data platform that you've been championing or have been thinking about.
Thank you so much, Fizan, and good morning to all of you. It's a pleasure to be here. And I salute you for all the work that you're doing, especially through the G4 Alliance. Commenting on the resolution, as you know, the resolution was adopted last year at the time when we were actually also looking at the SDGs. And as you saw, the resolution was crafted in a forward-thinking manner, even from its title, because we wanted it to be something that can be worked on as we work on the SDGs. That's why the resolution has UHC, and as you've seen, UHC is the main thing that is being discussed as far as health and the SDGs are concerned. And of course, in UHC, surgery is a key part of health system strengthening. There's been a lot of discussions on health system strengthening. Of course, other events have also sparked this discussion, like the Ebola outbreak. But nobody so far has fully discussed what do they mean when they talk about health system strengthening, or how will it look like in different countries. And so for us, first of all, as Zambia, and for me individually as a diplomat working in the UN, one key area that we've looked at, or that we already saw that would help the health system strengthening, was the issue of strengthening surgery at the district level, and hence the contents of the resolution and what it looks at. But then what has happened so far? Well, very little is happening in terms of tangible results, but there's a lot of movement still towards implementation of the resolution. You yourselves are a lot more involved in advocacy, resource mobilization, and you know where you are. Of course, you are just at the beginning of the whole thing. For us ourselves, as diplomats in Geneva, we keep watching WHO and we keep engaging WHO, but we don't want to push them too much, because they are required to report next year at the World Health Assembly on what they have done so far about the resolution. And as you know, the resolution is not finite. It doesn't have a time frame. It's something that will continue going on into the future. But then that also creates a challenge, the fact that when we crafted the resolution, because it was the first time we were getting such a resolution, we did not insert in there things that would block its adoption. Things like having a framework of implementation or an action plan of some sort. Because usually things like that require funding. And at the time when we were discussing this, we were not in any position to get anybody to put money into it. And there were the myths about surgery being an expensive venture. So we left out strategically some things, hoping that because we don't have a time frame, as you go forward, you can keep adding to it through the WHO or even the UN. Because now it's about time we started talking about an accountability framework. We have passed the resolution, we have the report from the Lancet, we have the DCP3 report. But what has been done? Who is accountable for this? Who can we ask? All the countries committed to do this. None of them, even the speeches that they made when they were adopting the resolution, including the EB, are there. But so how do we hold them accountable? What mechanism do we have in place? For us to keep the momentum and to move faster to implementation, we need that. And so this fora should start thinking about what would be the best. And it's not one piece. You can move on many, many fronts. But we need accountability because we feel that we're talking a lot. We're doing very little in tangible things on the ground. And that needs to be done. For us, then, as a country ourselves, well, we raised this issue at the UN because we had all the intention to carry it through at country level. So we've continued, and we were lucky to have many, many partners at country level that have always been helping us, and we're working on this. And the government itself, before even the resolution, was doing a lot of work. So on issues of infrastructure development, I think that is done by government, and they've been doing that very well. But again, it was done like everything else. It was not very specific for surgery. And so we needed something specific to track down what we're doing on every front, on infrastructure, on equipment, on human resources, on research, on supplies, on data management. All that needed to be tracked. Even financing for surgery needed to be tracked. And so how did we move? I'll give you just briefly, if you allow me, comments on what we have done in Zambia about implementing the resolution. As you know, first of all, the political commitment was there because the Minister of Health moved the motion to adopt the resolution. So that tied him. His hands were tied by him pushing that motion, so he was committed to it. When he came home, he gave directives for the ministry to move and start working on it. He didn't know how they were going to work on it. Good thing is that we have a very responsible permanent secretary, and we also had very good directors who are surgeons, who could move this issue already, and they were very keen because they were happy. So we had the right people also in the right place. I think that was a little bit of luck that I was talking about. We had to do an assessment of where we were as far as surgery at that level. But the assessment was done in all levels. The resolution talks about the district hospital, but we want to improve surgery at all levels. Of course, the district being the front line. We did an assessment, and we also had baseline data that was done through a Fulbright scholar who came from Harvard in 2010, who did an assessment of emergency and surgical services and anesthesia services in all facilities. So we had baseline information that showed us some of the gaps. Using that baseline information, and of course we had partners working with us because these things, to put people together, to discuss even in the preliminary stages, you need to bring people together. So we had partners working with us, local partners or partners that are on the ground and partners that came from outside. We had the Harvard team, we had fellows from the Lancet Commission on Global Surgery, from the Harvard Medical School, camp in Lusaka for the last 3 months, working with the Ministry of Health to try and work on developing a national surgical plan. And then we also had the Tropical Health Education Trust, THET, I think that's what it stands for. Also, they were on the ground. They facilitated the issues of coordinating meetings, sending out invitations, having refreshments in meetings, things like that. And of course, WHO country office didn't play a big role at all, which was kind of sad for us. And they were invited to all these meetings and they didn't show up. We know they don't have much capacity, but those are the things that we've always said about WHO's presence on the ground, that is very thin and it's very difficult. But anyway, so through these partners, the plan was to set up 3 committees. These committees were set up, and the committees were made of different diverse group of partners and professionals. And they then brainstormed and developed the initial drafts of what was going to constitute the National Surgical Plan. This work was finished, and then it was to be submitted to the technical committee headed by the permanent secretary that was to review and see if it fits the government document, and you know, they have to tweak it somehow. So the issue of working the National Surgical Plan, that work has already been done in the last, from January to now. And last week, before I came to the Assembly, I was in Lusaka where we launched the National Surgical Obstetric and Anesthesia Forum. That's what we're calling it, because for us, we want to bring all the groups that are involved in surgery together. So surgeons, obstetricians, anesthetists, that's how we're calling it. And they are very sensitive, as you know. If you leave out one, when you mention anything, they take offense. So we want to keep them together. You have to be sensitive to their sensitivities. So we just had the National Surgical Forum, where the final document was launched. Now, the process going forward is that this document is awaiting the development of the 7th National Development Plan. But it will be part of the document that forms the health component of the National Development Plan. Once this is incorporated like that, like we said in many fora before, we did it this way because we want the Zambian government itself to take responsibility in financing surgery. If it's not part of the National Health Strategic Plan or the 7th Development Plan, then the government cannot put in money. But if government cannot put in money, who's going to put in money? You yourselves have to start. You have to own the process. You have to show responsibility and do that. So that's where we're at in Zambia. By the end of this year, all the documents will be finalized, and we know that surgery will be part of the National Strategic Health Plan, and we'll have some budget lines from Zambia. As far as data, which is what Vizan asked me about, data management and how we want to do it. Yes, we want to have a robust data system. At the current stage, we're brainstorming. There are things that are very leading already that we know we're going to use. For example, we are in touch with the ZICTA, which is an authority that's responsible for all forms of communication. And we are working with them because we want them to help us to manage health information using mobile phone technology. How we will do it finally, we're not sure, but we know that we will need to use mobile phone technology because we want information to run quickly, to be dynamic so it can be used for different purposes, and to be as close to reality as possible. So we, at the current stage, we're picking on partners, and we were also trying to work out how we can do it, because already there's an information management system for health, which does not give detail. It cannot be useful at all for anything, not even for policy formulation, let alone research. So we need to change it. We know we need to use mobile phone technology and anything else, but in the current stage we are brainstorming. But the committee, of course, has given recommendations on this particular aspect and the options that are available. Of course, I'm keen to answer specific questions if I've left out anything.
Thank you so much, Emmanuel, for covering those topics. I'm going to turn now to the Minister of Health for a bit. Honorable Minister, you yourself are a cardiac surgeon, and I think you've been working with the G4 Alliance. If you would give us some of your thoughts around what specific activities we should be engaging in, and then even then particularly focus your comments around the strategy. I know Emmanuel mentioned a global accountability framework, and then we'll continue with some other questions.
Thank you, Chair. Excellency Ambassador Barsan, Dr. Emmanuel, dear friends and colleagues. I'm really honored to be here. I'm honored to be the first politician to be between you, and I'm grateful for the support that you have, or at least some of the organizations here or members of G4 have supported Libya during this difficult time. You are very strong. I think this is what you should keep in mind, and because your work talks about you. In Malawi, we spoke about cost effectiveness, and I think that message has to come loud and clear to the world. You are, I'm sure, more cost effective than many UN-based organizations, maybe even including the WHO. I won't be surprised. So the WHO should be honored to have you as partners rather than the other way around. I think we were talking outside that we said it's very important that the concept of what you do or the cost effectiveness of what you do should be delivered to the world. And I think collecting data between various members of G4 Alliance and publishing that in the form of a brief paper or even a letter to the editor of one of the journals will be probably a very strong advocacy for you and how you should be doing. The question is whether you should have a body based here in Geneva which will help you to recruit or be able to bring more funding support to the G4 Alliance members, or continue doing what you do is very important, because I think a decision you have to make. Because I was talking to Dr. Manuel and he said, well, having an office and a big team in Geneva may be too expensive for G4 Alliance on one hand, and he said also if he had that, for example, continue do what you're doing as it is, I think you need to do a cost analysis. What would be the best way that would guarantee whatever money you are getting through donors or through the United Nations is delivered to the individual, to the patient on the ground. I think the WHO member states, as Dr. Makasa have pointed out, have weaknesses in implementing the resolutions which came out last year, and we're expecting a report on the resolution next year. That report, I'm sure, will not be anywhere close to what we expected the day we supported the resolution. So we will be calling upon further need to push towards definite commitment to help the patients who need and to help the organization that deliver the service for surgery, obstetrics, anesthesia, and trauma care. These are essential things. Whether we should take that to New York, which is will be a good, again, political advocacy move, is to get a resolution from the General Assembly in New York to support G4 Alliance or to support patients who need the four services that we mentioned. In an indirect way supporting G4 Alliance and its endeavor. It's very important for us also to ask for a meeting with all ministers who you have provided service to. I'm sure you've been working in a number of countries, what, 10, 15, 20 or more?
All the organizations in 140.
Total 140 countries, and I think inviting those ministers to attend a meeting hosted by G4 and really to show the world that what you do is something that touches the individual on the ground. It's not simply sitting in nice hotels in Geneva and talking. You really are delivering good service. And the people who should know that, and people should push for that, are the ministers, because they know this more than any diplomats based in Geneva, for example, or even other ministers who have nothing to do with health services. But using G4 Alliance members to deliver the service on the ground is, I'm convinced, is highly cost effective. We do about 225 or 250 children open heart operation in Libya with William Novick, the Novick Heart Surgery Pediatric Charity, for less what costs me. I pay for the tickets, for example, and whatever equipments that we have to make available for the team to function with. It costs me the value, 250 patients, 250 of open heart operation, the value of operating on 2 or 3 children in Germany, open heart operations. So really is extremely cost effective. In the past, for example, some cases who need open heart operation, we send them to Germany, and the average cost of operation is about 70,000 euros per case. The overall cost for 250 cases operated by William Novick, what costs us in terms of tickets and accommodation, the logistic support for the team, and whatever equipments or supplies not available, not immediately available in Libya, is under $1 million, and you can do the maths. This message has to be delivered. What you do as G4 Alliance members is highly cost effective, is beneficial to people who need service, who otherwise die. They won't get it. Today in Libya, I don't have money to pay 70,000 euros for open heart surgery for children for 200 or 300 cases a year. So if I don't have William Novick Charity, I didn't have a G4 Alliance member today in Libya, most of these patients will die because we simply cannot afford to operate on them somewhere in advanced countries. So I think in terms of resource mobilization, step one, you have to show your work to the people. You are highly cost effective, and you have done so much last year, and the average cost per procedure is so much. From there, I think you will provide a compelling reason to donors and to countries in terms of support for G4 Alliance as a whole and for its individual members too. Advocacy, I think you're doing very well in terms of advocacy, but I'm not sure you're doing very well in terms of fund mobilization. But advocacy should be reflected in the form of funding at the same time. And policy implementation, I think Dr. Mukasa discussed that in details. I would like to see it written in a format which is approved by as many member states in the WHO as possible. I'm just wondering whether we should consider a separate resolution for policy implementation of the need for surgery and trauma in the developing world, at least. Thank you.
Thank you so much, Minister, for those comments. I think you're already segueing into what I'd like to really be a conversation now. So, Emmanuel, I think one of the most fascinating things you said is that that intentionally, when the resolution had been written, there's actually, you made it was unanimously approved. So you made it, in terms of the teeth of it, that you wanted to make it most acceptable. And that's what diplomats you have to do in terms of making it most acceptable to everybody to get the conversation going. And I was so excited to hear you said that it's time, and this is something we've been talking about, to think about an accountability framework. So how do we push ahead? And you know, we've always talked about this idea of having a UN major meeting in surgery. It was talked about this morning before you got here. What are your thoughts from each of you about that? And I also would like to hear from Ambassador Parson about that.
Yes, I mean, like I said, an accountability framework will help the implementation of the resolution, or actualize the resolution and everything else that we want to improve on surgery. Now, how do we do it? First of all, we need to stand on solid ground to call for an accountability framework, meaning that the different professional organizations that are making up G4, or indeed the national surgical professional organizations in each country, need to be alert and keep in mind and monitor what has been done so far since their governments made this commitment. They have to map that and put it together. G4 can put it together, because we need to say, so far since the resolution was passed, so has been done, or this has not been done, or what has been done is not up to what we expect you to do. You know what I'm saying? So you need the evidence of where we are or what has been done so far. That evidence, coupled with what the WHO itself is going to bring up at the next assembly. Now, to bring the evidence, obviously, you need to work with your members as you go towards the assembly, because we cannot call anything on them unless we have evidence that from them as well of what they have done. But basically, all this evidence will then be used to say we have not made the efforts, and I'm very sure we would not have good evidence. I mean, we will not have enough progress having been made in the 2 years. And then we can call for another resolution, yes, but the other resolution should be the resolution to adopt the accountability framework or to adopt the action plan. It should not be another resolution to call for action. No. We have the evidence, we start mobilizing to because it also needs, because like you clearly say, an accountability framework or an action plan will need money. And so far still, we are still in the money challenge situation. So we need a lot of, momentum. And that's why we need the evidence and to stand on solid ground.
Ambassador, from a regional health perspective, I mean, how do we make this push or call for it? One of the things is, I think we've talked a lot about WHO, but there's a very important component of regional health authorities. So if maybe you could comment on that in your perspectives.
Sure. Thank you for the question, and gentlemen, once again, welcome. I mean, to answer your question directly, Dr. Abdullah, I think probably the path of least resistance to get this to, I agree with you, Minister, in terms of getting it to New York. I think that's critical. And procedurally, if I'm to address the procedural aspect of it, probably the path of least resistance is to have the WHA, the World Health Assembly here in Geneva, incorporate that resolution 6815 as part of an omnibus resolution to be sponsored by 1 or 2 member states for authorship and delivery to New York. That procedurally, that will actually facilitate incorporation into the New York's agenda, which is part of the overall UN's passage, let's say September 2016. I totally support your suggestion of having the evidence, but I was giving Dr. Abdullah an experience of mine, at least in the Western Hemisphere, what we did, for example, when we had the NCD challenge. Very similar to the work of the NCD Alliance, I took a proposal to the Organization of American States a few years ago, and what we were able to do, and in fact I'm very happy to see it bearing fruit now, we were able to actually incorporate our work via a multilateral organization of the Organization of American States, partnering with PAHO, the Pan American Health Organization, and out of that create the equivalent of an inter-American task force on NCDs to actually operationalize the work required. So aside from the political strength of a resolution, the operational willingness to show machinery for delivery is what we did in parallel to actually have that, actionable. And I think a big part of this too is in any resolution, resolutions naturally lead to the production of mandates. Then prioritized mandates would then determine where we go from here. And I think spelling out the budgetary implications of a resolution is also critical in getting the initial support, because a lot we could speak about the issue, but then if we don't actually have countries committing politically and otherwise to fund it, it'll go nowhere fast. So these are some initial thoughts, Dr. Abdullah.
Thank you so much, Ambassador. So what is the, Minister, I'll turn to you. When a country makes, or to any of you, makes a political commitment, what is the funding implication of that? Is there a funding implication? Is there a mandatory funding implication if a political commitment and declaration is signed? Or how does that work for all of us who don't sit in the diplomatic space?
I think if the need for surgery is compelling to the international community, because we know so many kids died because they have no access to essential surgery, so many newborn and women die in labor, trauma, anesthesia, etc., etc. Then the UN will have to take responsibility towards this. And if that is approved through UN General Assembly, and a resolution said that we should support, then they will have to decide whether to create the equivalent of Global Fund or UNAIDS for surgery if the message is strong enough, or they say, okay, we simply politically support you and we'll be happy to cooperate with individual organizations dealing with surgery or G4 issues in terms of financial support, which is, it's difficult because if you don't know what's the safest way for you. Would you be better off to have a G4 alliance organization under the United Nations, which would be very difficult to get the UN bodies to agree to, but the advantage that you have guaranteed funding coming from the UN, or to carry on do what you're doing now and rely on individual countries' political commitment in New York and financial support that would follow. Because if a country agrees that this is an issue which should be funded, then they will have some form of ethical commitment to fund it. But this may last 1 or 2 or 5 years and then eventually could die away. But I think the advantage of the last option is that, to me, it will be much more cost-effective and probably easier to follow. But maybe Ambassador Parson could advise us what would be the best way to go forward. Whether should aim for a UN-related body that will steer the work of the G4 alliance or organizations dealing with surgery, obstetric, trauma, and anesthesia, or shall we just carry on doing what we're doing today?
I mean, that requires a bit of thought, but for example, the model that we used with the Inter-American Task Force on NCDs, that task force was created with the idea of broadening stakeholdership engagement. So for example, we had the Organization of American States, we had the Pan American Health Organization, and that facilitated us to co-opt the United Nations Economic Commission, ECLAC, who perform a lot of studies and would provide the data for it, and then we incorporated as well the World Bank, the Inter-American Development Bank, because these entities were actually funding projects, but we weren't necessarily cross-cutting and cross-fertilizing efforts for one cause. So I think that would require looking at the models out there and understanding the role that the G4 Alliance can play in actually bringing the functional areas required to go after operationalizing the resolution. Obviously, clearly funding is one issue, but then the actual warm bodies required for the delivery of the end product, which is advocating for the neglected surgical patient, bringing surgery. I think we need to sit down and look at a hybrid model, probably of international organizations, donorship organizations, and then figure out, we all have our place in the sun, but know our place in the sun. What's our place in the sun? And I think that requires a very broad conversation with all stakeholders around this room. But there are models that we can look at, and I suspect we will clearly have to hybridize a model that suits the need of this alliance.
May I just come? Yes. Just to add my thoughts to the way forward, or what options you can have. Obviously, you have a lot of good people here who would work it out, but we can just share our thoughts. I don't think that there's only one way that you can approach the future. And I don't think you should only use one way to go forward. You should use all means possible to move every piece that you're moving that are part of the principles of advocacy, resource mobilization and actual implementation. So don't look at one option. Consider all options and move, if you can, on all fronts. Yes, indeed, we had actually hoped that we could take this to the UN, but we couldn't because we were overwhelmed by the Ebola outbreak and there were too many things to do. And we needed to coordinate very strongly with New York missions to do this. Like Ambassador said, and the Minister said, it would need some member states to table it, that side again. So the UN option is still something you can consider because it's a stronger level, it's a higher level of commitment. And of course, building on what the countries have already committed at WHO. There you could get a declaration, you could get a goodwill ambassador as well. It's not one or the other, it could be both, or it could be the other options that my colleagues have described here. Because you need to continue advocating. Yes, you have already got the organization that advocates, but why don't you have one of yourselves as a goodwill ambassador to continue at that level? Because then you have the political mandate as a goodwill ambassador to actually continue, and the advocacy will also bring resources and can spur the countries to start implementing. It can do a lot for you. So there are those UN options. At the WHO, we've already said that the next phase now we have to prepare is having an accountability forum or an action plan. That is needed as the next phase. When we do it, again, we can strategically work with the time and the cycles of the organization to see if that can be done. It will take countries. Of course, the same countries could go ahead and add to this. Countries, you also have to work with the individual countries. You shouldn't forget that. That's actually the bigger part, because everything else is up in the air. At the country level is actually where the action is and where we'll see what G4 can do. That commitment is important, and you have to carry it through. You have to pick on countries that are willing to move forward, because you need good results quickly. You can't pick on countries that are very difficult, that are not willing, that don't show commitment, because we are still in the first early stages of this process and this movement. I will give you assurances that countries, for example, in the Southern African region are very, very keen to move forward. So we know that some countries are not willing. We've heard about comments from Asia about even the regional director not being very keen on this. We don't know. We can't comment. But we know for Southern Africa, almost all the countries are very, very keen and are running to move forward. I was in South Africa at the National Health Forum. I'm in touch even right now at the WHO with the Minister of Health of Zimbabwe, and I'm in touch with all their colleagues at country level. Namibia is doing the same. So the motion, and Madagascar, as you know, is also already trying to do this through the minister. So those countries are moving. Those countries could be good countries to work with to score and secure, positives. But the bigger thing is also that these countries don't know how to do it. They made the commitment through the resolution, but they don't know how do we actually do it. They don't know. That's what I've learned from my experience moving around and talking to them. None of them knows how are they going to translate the policy through the resolution to actual something on the ground. They don't know how to do that. And that's where you come in. Because if you can help them work it out, how do they move from a resolution to actually things on the ground? What is it that they can do as a government if they don't want to take everything? And what other things can be helped through the G4, for example, on human resources? You have COSEXA here that is big in training, and it keeps increasing. There are things that you can manage to help them with, and there are things that they should handle themselves. Issues of infrastructure and equipment are their responsibility. Those are capital projects. They cost a lot of money. But the other things, you have association. COSEXA is doing a great job on training human resources in the region. Very soon they're going to have enough. And then there's also the other partners like funding organizations. Those, again, you have to continue to talk to as you try to mobilize. So these are many areas, pieces that can be moved going forward.
Thank you so much to all three of you for just amazing comments. And I know both of you have to get to other engagements, but I do want to open the floor for a few minutes to our board for any questions from the floor. I could literally sit here for hours to discuss this with you, and I wouldn't tire on the subject because it's such an important subject for all of us who are so passionate to try and make sure that this care gets provided to the people who need it. So any questions from the floor? Yes. Charles, please announce your name and organization, please.
So my name is Charles. I'm the Chief Executive of the Primary Trauma Care Foundation that works in 75 countries. And thank you, Your Excellencies, for a very stimulating conversation today. My question is about ethics, and I noticed this came in Dr. Oakley's comments about ethical considerations. And to put it rather bluntly, the choices sometimes are, do you do heart surgery on one child, or for the same money, could you save the lives of 1,000 children in very simple interventions out there at the extreme edges of poverty? And I noticed in Zambia, and I was in Zambia recently, the ethical choices that the Ministry of Health had taken to install outposts in hundreds of locations all over the country, with at least one trained nurse in every outpost. That was a decision to push it to the extremes and to provide for the poorest. So my question is, as we consider the Global Alliance's mission, what do you think will be, excuse me interrupting myself here, but for our own sake, I wonder whether we should install an ethical component in one of our working groups, and I would suggest it should be under Sir Hale's group, the standards and guidelines. But we can perhaps consider that outside this meeting. But my question is really, what do you think will be the big ethical challenges for the Global Alliance?
I think you could use it to your advantage, in fact, if you persuade member states that they have ethical commitment to care about those who need surgery and obstetric service, etc. I think that will work to your advantage. But if you go into the philosophical question whether we should be doing open heart operation or doing vaccines, I think that would be a completely different ball game. However, in our country at least, we're able to do both. I think so. There's no ethical dilemma there. We're capable to pay for vaccine or also for open heart operation, but not at the cost that we said the social costs in developed countries, which can be very expensive. Therefore, I think installing an ethical department under G4 Alliance will be highly appropriate. And the aim is to get these individual countries to commit ethically to treating kids with cleft palates and women in labor or obstructed labor, and those who need anesthesia and those who need trauma, whether during time of peace or during time of disasters like many countries are going through today.
Thank you for that question, and thank you, Your Excellency, for that response. I'm going to recognize the Vice Chair of the G4 Alliance, Professor Pankaj Jani.
Thank you very much, Fizan. My question is to Emmanuel. Emmanuel, you have sort of enlightened us with the information that there are certain countries, especially the Asian group, which is not very keen on getting bored with this resolution implementation and all that. And you mentioned Madagascar, Zimbabwe, Kenya, and the other countries. How would the next step be with getting these ministers involved? I mean, at what forum should we get the ministers involved, and how can you, as a diplomat based in Geneva, assist with this? What would your recommendation be? Because I am thinking that if Zambia has already got a national surgical care plan and is trying to put it into a development plan, Kenya is working on that, Ethiopia has already got it, Malawi is nowhere, but through COSEXA efforts, how can we get these ministers, and at what forum should we engage them? Thank you.
Thank you. Maybe just comments on the ethics, and then I come to that question. I fully support the Minister, what he has said about ethics. I think the only ethics you should be championing are ethics of the responsibility to provide surgery to the poor, and also the ethics of the standards, because it will involve scaling up. We do not want mistakes. We don't want bad mistakes that will give the whole thing that we're doing a bad name and stop the whole process. I think those are the only ethics that you have to champion. Whether ethics of whether surgery or immunization, that's not a debate we want to have, because we've already proven why surgery is really important. It's just as important as immunization. So that's not a debate we can have again. Coming to the questions raised by Professor, the ministers are actually willing already. What I said about the sub-region wanting to do this is through my interaction with the ministers themselves. I've had interaction with the Minister of Health of Namibia, the Minister of Health of Zimbabwe, the Minister of Health of Madagascar. These are the people who are asking us that we want to move forward. How do we do it? So we asked them to put us in touch with their technocrats in the ministry and their professional organizations in their countries. So because the minister is not going to do it, he wants to do it, but he gives us the people who can do this. So in the current stage, we are in contact with these people to try and work out how they can start the whole process, building on what we know of what we have done, and also from the meetings that we've had, for example, through the Lancet Commission, about what India is doing and what Cape Verde is doing and other countries. So the ministers are willing already. You don't need to convince them. They want this. They are the ones looking for these opportunities for their people. But where do we meet them? I think you have to use the mother body of the COSEXA. The EXA is a ministerial intergovernmental process, and they do have meetings. And we are in touch and we are in contact, even as surgeons here, very strongly with the board and the chair of the EXA. The EXA stands for East Central and Southern African Health Community. It starts from, I think, Ethiopia, going all the way down. So that fora will be the best. And we can, using the director of EXA, put an agenda item on their ministerial meeting where this can be discussed in full and then commit. Because they also need to start financing COSEXA. COSEXA is providing a lot of human resource, but it's not getting any money from the governments themselves, and that needs to change.
Yes, and Your Excellency, I'm just going to give, there's 4 placards up. I'd ask that no other placards go up, and then I'll bring it to a conclusion in a moment.
Thank you, Dr. Manuel. I think I will go even beyond what you suggested. I think we should invite all ministers who are benefiting from G4 Alliance to come to the meeting next year. They should be invited here and make a statement. They should come up with a statement in support of these organizations who are doing their best to try to help their people. That's number one. And number two, I think that I forgot to talk about 2016, because this coming September, we're talking about AMR at the UN. So it may be a good idea not to try to, I'm not sure that we agree to accept both at the same year, because especially if it involves financial commitment. So maybe we should be aiming to the UN or GNA in the next year's meeting. Thank you.
Thank you, Your Excellency. So I'm going to ask, it's 12:09, we have to be done by 12:15. We've already taken 15 additional minutes from our distinguished guests. So I'm going to ask each of the folks who have placards up literally to give 30-second questions, and then I'll ask each of our distinguished guests and our chair of the meeting to give their concluding comments. So I'm just going to go from the right. So Catherine, and please, again, your name, full organization, and each person, and then the quick comment.
Catherine DeVries, University of Utah. My question is for Dr. Makasa, because you in Zambia have done just an exemplary job of inventory of the surgical resources within the country and creating evidence for the country of what the needs are. And I think those have been done in collaboration with your Fulbright scholar and with other outside resources. If you were to give guidance to other countries how they can do this kind of inventory and build the evidence for needing their surgical plans and for how where the gaps are, how would you help the other countries to establish the really fine documents that you have done to establish it for Zambia?
Wonderful, and we'll take it all together. So Dennis Robson.
Dennis Robson, Fistula Foundation. A question also for Dr. Makasa. I'd like to see some practical examples of members of the G4 Alliance collaborating together at a local level, and I wondered if that could be integrated into your national surgical plan for Zambia. Thank you.
Thank you. Robert Lane.
Just very briefly, I'm not surprised by what Emmanuel tells us, but I think partly it's all very well getting ministers of health to a meeting for 3 or 4 hours or a whole day. Would it be more value for members of the Alliance, suitable members of the Alliance, to actually spend 2 or 3 days with countries who really need help and advice as to how they should proceed? They're keen to go, but I get the impression from you that they don't quite know how to go. Would this be of any value? And finally, I don't know whether anybody's mentioned the Africa Union. What is their place in all this?
Wonderful. Brendan Allen, our new Executive Director.
Thank you. Perhaps more of an operational question, but we're trying to strengthen surgical systems using a health system strengthening approach. That implies working across many other sectors at national level, particularly ministries of finance, ministries of education. What guidance would you give to include multiple ministries in supporting these plans?
Wonderful. So we'll just ask concluding statements from each of our distinguished guests, and they may answer those questions. We'll begin with Emmanuel, and then we'll go to the ambassador, and then finally with the minister.
Thank you. On the inventory, how can countries actually do this work? First of all, of course, like we said, they cannot move forward unless they know where they are. To know where they are, they have to do an assessment of their services. And the tools are available to do this. WHO has developed a tool that we have used, which was used even by the Fulbright scholar, like I said. So there's a tool that you use to do the assessment. It's available, including costing the gaps. So that's already there. That could easily be used. How it is done, therefore, in our setting, it's something that needs a research person to go and to each institution and actually check physically what is there. It's not something that can be done electronically. You send it out and then you receive feedback, usually. And then it has to be analyzed after that. I think that's as simple as we did it. So the bigger component comes to finding the person or who can do that. It doesn't cost much. And then, of course, do you use different people? Do you use one person? And some countries are huge. I think those are the only logistics that have to be considered. But that's how they can do it. And I think they can use WHO and that have developed the tools in doing this assessment. And many countries have already done those assessments. Practical examples of collaboration on the ground. Yes, indeed, they are there. Already for us, a practical example is that we have COSEXA, who is part of the G4 Alliance, collaborating with the Surgical Society of Zambia, which is a local professional organization on the ground, which is not part of the G4 Alliance, I think. And we have members who are part of COSEX and who are part of the Surgical Society, who are key members of the committees that were part of the process of developing the national surgical plans. Obviously, the training component will be what will be strengthened or as far as collaboration with COSEXA when we come to the implementation, and those aspects will be reflected, obviously, in the national surgical plan. The value of sitting with ministers. I think both could work. It's important to continue quoting the ministers here and to raise the profile of the work that you are doing, and also to encourage them in the work that they are doing. So their presence here wouldn't hurt. I think it would be a good thing. But there's a lot of value also in, after that collaboration that you have with them here, you can identify who is willing, because they might even invite you from this fora. Then you can follow up and plan with them that 4 days sitting down with them and working it out. So I think you can use both. They can be helpful. The African Union's role. The African Union is very new to health. Mostly it has not worked on health. It has worked on politics and governance and elections and things like, and wars. It's until the Ebola outbreak that the African Union tried to start doing something on health. And the first thing they are doing is obviously infectious and communicable diseases by setting up the African CDC. Its formation is still not yet done because we're still setting out collaboration centers. Yesterday we were in the African ministers meeting and there was a lot of, oh, we want to collaborate. Anyway, it's a new thing. It has not really been worked out. They're starting with infectious diseases, but obviously we will put all the pieces there. NCDs, surgery, we will put the pieces as they get to grips with healthcare. I think they're very new. So there's nothing there yet, but they have started, and we can continue looking at them and working with them. And engaging with other ministries. Yes, indeed. I mean, there are components that, for example, the issue of surgery, you need, whether you come up with a national surgical plan, implementation, you need money. Money comes from Ministry of Finance. They have to be sure and agree with it. So there's that collabo that needs to be done with the ministry or engagement. And also engagement with the Ministry of Education, yes, indeed. Because training, the setting is different in different countries. In my country, the training is strictly in the hands of education. It's not in the hands of health. Health only takes the professionals after they are trained. But education has to understand what we're trying to do. And of course, there's the issue of new cadres, because we can never only rely on the professional trained surgeons and anesthetists. There's this issue of task sharing. We need more people. And we need the ministries of education to understand that aspect, to accredit those professionals, to give them licenses so they can actually be employed and be paid, because they're not going to be volunteers. So there's a lot of room of that, but that has to be done at country level. Yeah. Comments? I'm very grateful to be here, and I salute your work, and keep it up. I think you're doing a good job. That's all I can say in conclusion. Yeah. Thank you.
Thank you, Fazan, and I'll be very brief. You have heard enough of me for the last day and a half. But I would just respectfully suggest that we probably want to link all our work to something bigger and something that's accountable, and that's actually the Sustainable Development Goals. All countries back in September 2015 took a commitment, and that's where the accountability comes in, post-millennium goals to follow Agenda 2030. Goal number 3 is directly related to health. And out of the 17 goals, 169 indicators, 8 are indirectly related to health, including poverty, education, etc. And 1 is directly related to Sustainable Development Goal number 3. Out of the 169 indicators, 83 are indirectly related to health. So I feel if we can actually peg our work, for example, the presentation we had earlier this morning on unifying global targets, what is that linked to? What's bigger? And that is the Sustainable Development Goals number 3, Agenda 2030. And I feel that's a conversation we ought to have. That in and itself would feed itself into what can we do here. We heard examples coming from Zambia to facilitate a platform of advocating for the negative surgical patient around best practice exchange. So practically speaking, we have done our work, we have come up with the policies, we have advocated, others are doing it. How can we actually take these pilots and extrapolate it, export it, repackage it elsewhere, so that we have a platform for best practice exchange? And lastly, I think after we finish our work here and we have a clearer sense of direction, how can we take our membership here at a country level and actually incorporate it into the strategic planning process at a country level for ministries of health. And Aline, to touch on your question, I think the SDG goal number 3 in and itself is inherently interministerial and intersectoral. It does touch the ministries of finance, ministries of education, ministries of health, ministries of development from the poverty eradication standpoint. So those are some closing comments, Dr. Abdullah. And again, thank you very much, gentlemen, for being here and having the opportunity to interact with you on a mutual cause of interest to all of us. Thank you.
All right, I'll be brief, or as brief as I can. I think I will only address the issue whether should G4 go to individual ministers. I think it's a great idea. They should do that too. But at the same time, I think calling them here for a general meeting will be appropriate. Moreover, today we had an EMRO group meeting. All ministers and ambassadors belonging to the East Mediterranean group are in a meeting at the WHO. I left that meeting to come here. I'm sure many of them, if they know G4 and what they do, they would be happy. They would have been happier to come and join me rather than sitting at the WHO office. For that reason, it may be a good idea next year that to request G4 to request a meeting with regional meetings which happen just before the WHO, maybe Sunday or Saturday. It could work. It could work well. Finally, you're doing a great job. Thank you for that. But I would like to see more of you in Libya. Thank you very much indeed.
Your Excellencies, I can't express on behalf of the entire G4 Alliance Permanent Council and Board of Directors our immense gratitude to all three of you for taking time out of your busy schedules to be here with us. I would say, again, I'm safe to say that I think for all of us, we found this to be an incredibly stimulating and enlightening session. And again, we look forward to your, and we're so thankful for your being the champions for our community. And I know that we're very excited to work with you on an ongoing basis. I know we have our advocacy event tomorrow night, so that is something that you could actually help us convey the message to other ministers of health. 6 p.m. here in the same room that's the purpose of the event. Thank you for putting that up. In terms of our event, and we'll be talking about the importance of surgery in the global health agenda. And so we're really excited I think we have both of you and all three of you as speakers there. And so we're looking forward to that. So thank you so much. And I think just we're going to conclude the session. It's 12:20. For the board members, we're going to shorten lunch because this was an important discussion. We'll be here right back at 1 o'clock, so 40 minutes for lunch. Thank you very much, everyone.
What time is it going to be?
6 p.m. Yes.
And just a reminder that if anyone is interested or able to join us to discuss the nominating committee, we'll be at a table in the back for lunch. Come find us.
too many promising individuals fell through the cracks.
working groups. And we have 4 groups to present. And I'm going to ask that each chair presents the key elements for 5 minutes, and we will then open the floor for 5 minutes of discussions. And I'm happy that Dr. Adel Haider is back on time, and he would be given the floor first, together with, I'm assuming, his co-chair, Labna Samad. So Dr. Haider, you would be presenting the key elements, key messages, and national goals, targets, and indicators. For 5 minutes, the floor is yours, Doctor. Thank you.
Thank you very much, Ambassador Parson. How was lunch, everybody? Everybody's good? Yeah. All right, great. Can we have the first slide? Before I present what we talked about in our working group, we just wanted to throw up this slide for the key messages for everybody to take a very quick look at. I'll let you read it for about 30 seconds. So I just wanted to point out what these key messages are. And then the next set of slides that we have are, I kind of already went through them about why, what we needed and so on. So I'm just going to jump right to why we had, or what we discussed in our breakout group. And what we discussed in our breakout group were essentially 3 things. The first was how these indicators that we've come up with, how do they relate to the Lancet Commission indicators, and how do countries actually collect them? And the consensus was that countries will collect indicators, and I want to see if I have a slide of the indicators. Maybe we need to get new batteries in this thing, but hopefully the slide of the, here we go. For countries to collect these indicators, what was discussed is that at the ground level, there needs to be some impetus. And usually that's some external organization like the WHO or World Bank suggesting to a country that you must collect such and such. And so now that the Lancet indicators, several of them, at least 4 of them, have been adopted by the World Bank officially, the idea was that we should probably move these indicators to a situation where we very clearly say that the first 6, the Lancet ones, 4 of them are World Bank indicators, then there are 2 more. We say that these are the first ones you must collect, and then if you're able to, we also propose these 15. But do them if you can do all 15 to begin with, awesome. If not, do them in a kind of a staggered, staged fashion. And that's the first thing that we discussed in our meeting. The second question was regarding, the second point was regarding what we think the committee should be doing in the future. And should the committee be disbanded, or is our work done now that we've done these indicators? And what was proposed is that the committee not be disbanded right now, but the committee be charged with the next set of work, which is to kind of follow and evaluate countries as they build national surgical plans. So step 1 would be to first see which countries are even working with national surgical plans, and then come up with some sort of grading system or follow-up system to see how they're doing across the spectrum. And there are various different ways that we could do that. But we didn't want to just do that in isolation. We felt that it would need to be done in conjunction with the Standards and Guidelines Committee and other groups to see how implementation is going and so on. And then the third thing was regarding implementation. So what did our group think about implementation? And you asked us to make sure we discuss this. What the group felt was that implementation is an important thing, but we need to kind of talk about what implementation is and how it works. In the sense that many of our organizations that are representing the G4 are working on implementation on their own. And so what we, as this committee and helping other committees, should be focused on is developing a platform that people can use to do implementation. And so create material and standards on how implementation could be done, and then help our organizations do it. And in some cases, if directly approached, we could be involved with implementation as well. But the baseline would be to have a library of resources to help with implementation. So those were the 3 points that, again, you know, how do we break this out into primary indicators almost, and then the next set of indicators. The second thing was that we think we can monitor national surgical plans. And the third thing was that, yes, we should develop some resources around implementation. So I hope I got what the committee thought. Lubna, any further comments on this?
I think what we wanted to emphasize is, regardless of the source of what the indicators are, be it the Lancet Commission or DCP3 or any other body that may or may not be a member of this alliance, the important thing is if it is mandated by a government, by a United Nations or by this World Bank or by the WHO, then the chances that it would be taken up as or seen or perceived as mandatory by a country would be much higher. So that would be group 1 of indicators. If it's part of the UN 100 or if it's part of the World Bank indicators that are required, that would be group 1. Group 2 would be those indicators that may not be mandated but are generic and important to across surgical systems. So I think 4 of the 6 Lancet indicators, for example, are part of group 1, but the other 2 would come into group 2, as would other indicators. And group 3 are those that may either be relevant geographically or to a specialty, and it may or may not be relevant for that particular country to include. And in addition to relevance, obviously, feasibility is going to be important. So we kind of guide the countries to say that group 1 is non-negotiable. That's your starting point. Group 2 is what you should be working towards, and group 3 is really individual, need dependent.
Thank you so much to the committee for your hard work and really nice summary in a short amount of time. I guess, Dr. Hyder and Dr. Samad, could you comment? I think it's important to recognize, and I think you briefly alluded to it, that these are not new indicators, but that they are existing, whether it's World Bank, WHO, that's collecting these. So I think that's I would ask for you to comment on that.
Yes, and we went over this in the committee. The first thing the committee did, back last year, was to go over all the indicators that are available. And all of these indicators are published and kind of vetted, and that's why they were selected. No new indicators were created, and we didn't think that we had the ability or time to create any new indicators. Just to remind people of the Lancet process, there were at least 80 person years of effort put towards creating those indicators.
Thank you. We have 4 placards up and we have 5 minutes to deliver.
Yes, I was in the group this morning and we have got this discussion concerning the indicators. I was personally asking for having at least not new indicators but to have more detailed indicators. Because when we are using the World Bank indicators and the Lancet Commission indicators concerning the workforce, there are some problems of identifying the workforce. We are referring to anesthetists and surgeons, while we should address anesthesia providers and surgery providers. That is totally different because it gives some different details, and especially when we want to achieve this issue of safety surgery everywhere. I mean, this issue has to be known and has to be, we need to identify. So I think that that's something that is missing in the existing indicators developed by the Lancet Commission and by the World Bank, is to have more details about what is the workforce, what is the training of the workforce. Is it only physicians or we know that it's only non-physician providers. So I think that it's something that the G4 could get as information, but the reaction was not to duplicate indicators and to use the one that are mandatory, because it would be more difficult than to get the how to collect the data and to interpret the data. But I really think, and really insist on this, I really think that we need to have this detailed data about the existing workforce.
Thank you, Survey comments. Finley?
Can I assume that there might in future be a second level of this? These are fairly coarse-grained measures, immediate post-perioperative mortality, nothing about late mortality, morbidity, readmission, resurgery, other complications. Clearly, I'm interested in pain management, but all these other issues are of concern. I suppose one could say once we beat the post-perioperative mortality numbers down, then we start looking at perioperative morbidity, but it would be nice to at least have a sort of long-term concept of looking at that.
Point taken. Thank you kindly. McGee?
Thank you very much. I certainly take the point about the actual providers versus specialist doctors, but I do think that perhaps it's strategic not, to stick with what we're proposing on this one. But on a more general question about the 15 versus the 6, I think Adil and Lubna, and clearly the discussion this morning has been very, very fruitful, and that dialogue, as he described it, I think is much more inclusive and doesn't really create a sort of scenario of our indicators versus the Lancet Commission, and I think that's a very positive evolution of this. And I suppose my question then is, given that that is the way in which our thoughts have evolved over this meeting, does there need to be an evolution in the manuscript that's proposed to be submitted that would reflect that? And I think that would be a very positive action. Thank you.
Sorry, I turned it off.
I did, sorry.
It's all right. So I think the OBGYNs around the table will continue to bring lessons forward from the reproductive health and maternal health community. So one from the maternal health community, they started out only looking at MMR. That's it. Who's dying, who's not dying, simple metric, you're dead or you're not. And then they've lived their way into realizing that they waited too long to take morbidities seriously. WHO just finalized the statement on maternal morbidities in 2013, and I've just sent it to both of you. I think it's easy to literally extrapolate this language and create very substantive definition of surgical morbidity for this group for a near future rather than a far future engagement. It's crucial. And in fistula, we live in that world. And in fistula, we're seeing ever increasing proportions of iatrogenic fistula. The going rate is about 15%. But just yesterday, I got an email from one of our teams in Panzi on outreach. They went to a site in eastern Congo, and they had 80% of the fistula cases iatrogenic. So a word from the field.
Adil, if you're okay with this, I'll dwell upon some of them, but leave the manuscript bit entirely to you. First of all, I think the point about providers is 100% valid. The specialists, just picking up one of the indicators, which is the surgeons, anesthetists, and obstetricians ratio, these are specialists that you're counting, and not the reflective at all times of the different kinds of workforces that are providing care on the ground. I think the discussion around that during the development of the indicator was a realization of how hard it is to collect even this kind of specialist data. When we come on to how do you define a provider, at what level, how is it going to be different in one country as opposed to the other, the Feasibility of it was what was questioned and thought to be perhaps a little too difficult to bring together at this early stage. So again, the importance is not in doubt. The feasibility to collect in a country where even basic data collection or operative logs aren't available for at a government level, that was what was questioned in that particular aspect. Again, similarly, the finer indicators are important. I don't think there's anything stopping people from collecting those finer indicators. I think if you want to take it from 15 to 150, if your database so allows, and again, if it is focused on one area, it might be easier than across the board for all surgical specialties. There is nothing stopping us from collecting those. What we're talking about is what are we mandating as essential in countries where getting the most basic data, infant mortality rate validities are questioned, vaccination rates in Pakistan are questioned. So for there to go into finer indicators at an early stage may be disheartening for countries that are way back in the process. Again, I'd let Adil comment on the manuscript, but I think it's important to note that it is not 15 versus the 6 Lancet indicators. It is only 4 of them, if I am correct, that are part of the World Bank indicators so far. So out of those 6, only 4 would go into Group 1 and not the other 2. So I think that 15 versus 6 division is something that we should all try and put aside. And again, I think, Laurie, from your comments on the maternal health, again, the important lesson is how early in the process to bring in the other indicators. But I think what we were looking at with this first set are a start, and in no way a definitive predefined roadmap.
Thank you, Lubna. One thing I was just thinking about, Mr. McGee, is that the great thing about having a group like this and an open discussion is that you're able to evolve and make things better. And just like you said, the manuscript will appropriately evolve. The last thing I do need to bring up, Ambassador Parson, was something that was brought up in our group, and we were going to tackle this, and I think the Guidelines Committee was going to work on it. Maybe I'm throwing you guys under the bus. I apologize. But what is the definition of surgery? And have we set ourselves on that? Up till now, our working thing was that if you give pain relief of some sort, that's some sort of surgery. But when we say safe surgical care, how we should all know what our definition of surgery is. And that's something that I think we should really resolve.
Thank you, Adil, for your contribution and answering some of the comments. I see there are 2 requests. There's one request to the floor. You can have the floor, ma'am.
Yes, Catherine DeVries from Utah. There's been some discussion, I know, in the Lancet group, and I'm not sure that it's come up for discussion with our group about surgical workforce, but maybe it has, and I just haven't heard it. The question is how much of the workforce is indigenous and how much of it is provided by other resources like Cuba or like Chinese or other groups that are working to supplement indigenous workforces, and how do we account for those?
So these discussions have come up, but we have not made a specific comment on this as far as the indicators go. I think what's going to be noticed is that this work, we're going to start with this set as discussed, and that as time goes on, we'll be talking about more granular issues, including the issue of like who actually provides care, anesthesiologist versus a nurse anesthetist versus somebody with no credentialed training. So those are things that we do need to think about. But I would like us to, at some point, Ambassador Parson, to try to drill down and have an answer to people if somebody asks us, what do we mean by surgery? And maybe the Guidelines Committee Standards and Guidelines Committee can also give us some input on that. Thank you very much.
Catherine, if I may, I think what you're really asking is how do you disaggregate the SAO ratio into indigenous versus imported or possibly temporary workforce, which translates into a very different ground reality. I think the conversations around this would lead us to believe that those registered with the medical registries of a country are usually, not always, usually those that are locally, local people. And perhaps our, as a G4 Alliance, one of the areas where we have agreed to work on is defining or trying to map where different groups are working internationally. And perhaps that is the forum where this data on which countries are having larger larger foreign expertise versus those could be derived from. But usually, and I'm very willing to be corrected, usually registries, workforce registries take into account local workforces across most countries.
I think it's important to note that because it helps ministries of health know how they need to build their training or whether it's more cost effective for them to import and where they make their decisions on investment.
Just to wrap that up, it seems like one of the things that did come in the discussion was, you know, how do we track the national surgical plans of 190 countries? And does our committee, should we be picking some countries and try to track them as a model? Or should we be just trying to like do everybody and just say this country has a plan, this country doesn't have a plan? Maybe the first thing is to just have an inventory and then talk about how good it's working and so on. And I think once we develop that, then we can work on all these next kind of granular steps.
Thank you, Dr. Haider and Dr. Samad, for your intervention and the questions on the floor. And I know you directed a question or comment directly at the chair, and I would happily ask the subsequent presenting working group if they are in a position to respond to it. If not, it has to be noted for response at some time. I would pass the floor to Dr. Abdullah for just a moment, and then we'll go on to the second working group. Dr. Abdullah, the floor is yours.
Yeah, I also want to thank the working group for an outstanding job. I think that, again, the issue around our unifying target, I didn't hear from the group about the unifying target, but since you're the group that already has generated it, that's fine.
I'm sorry, the third point that we talked about was kind of regarding the unifying target was, you know, working with the implementation point that we talked about. That was our suggestion towards a unifying target.
No, and that's fine. And again, today is just the initial discussion around that. I think we have to remember that the unifying target goes hand in glove with the indicators. I think when we heard it directly from diplomats today that they don't know what a surgical system is. So I think to speak to Lubna's point, you're absolutely right. It needs to be really simple. And, you know, I guess I have some concern around, you know, I think we're the G4 Alliance. If you're building a surgical system, these are the things that are already being measured, but these are the subcomponent of whatever 14 things that we think reflect a surgical system as best as we can measure it today in terms of existing indicators. I think also we have to be really careful. The indicator conversation is an iterative one, because maybe as we realize, maybe, you know, getting measuring the professionals is not the right answer, because most of the care that will be provided in low and middle income countries may not be those who are fully qualified surgeons or anesthetists. I mean, just be completely measuring the wrong thing. So I think it's really, we have to be very thoughtful and circumspect about it, because this is not going to be, you know, a final discussion. But I think, again, as a G4 Alliance, a multidisciplinary alliance, saying these are the things, that these are the multidisciplinary things that we think are important, that's a good approach. Thank you, Ambassador.
Thank you. Thank you, Dr. Abdullah. We would move to item 6.2, which is the presentation of key elements by the Surgical Standards Working Group, and I will ask Dr. Susie Anil to take the floor, please.
Thank you very much. So we were known originally as the Standards and Guidelines Committee, and then following a discussion by Dr. De Vries and Dr. Romanzi with Walt, we've taken it down to standards for multiple reasons. And just to give you an overview, so we're going to give you a synopsis of what's happened. So if I can have the next slide, please. So one of the things we thought about is that we have come up with quite a lot of information about different standards and different committees and different organizations and professional bodies. You need to go back, please. That slide, thank you. And we hadn't really thought through the whole process fully, except in certain arenas. So we're going to present this as the three of us, and the first thing we are thinking of is the overarching, the overarching concept of really understanding what a country needs, each individual country needs. So if you have a country with X number of people, how many doctors do you actually need, in which disciplines, how many nurses do you actually need, etc. And looking at, there's a huge amount of data, so we're going to look at that as an overarching group. And the medical students, Izzy and the team, I think Izzy's there, we're going to work together to look at that, to sort of look at that as baseline data for a starting point. And then we're going to look at the different units, and we're looking at the three-tier system. I'm going to hand over to Laurie, who's going to go through the three-tier system briefly.
You'll see that so we have the three tiers. Can you go back one, please? Okay, go for, right there, thank you. The three-tiered system actually feeds into, again, another lesson learned from maternity care, from a maternal and reproductive health arena, where we have the BMONC and EMONC levels of centers. You have basic maternity obstetric care and emergency maternity obstetric care. And for the immediate future, again, there's right now and then there's near future. So in the near future, we can get to the third level of referral. I'm going to move backwards. And to begin to answer the question about what is a surgery from our prior panelists, we're following table 1.1 in the DCP3, the essential 44 surgeries. It's a good place to begin. It's not for us to extrapolate beyond that. That's for ministries and individual sites to extrapolate, but it's a legitimate question, what is a surgery? Because if you look at that list, you have things like normal delivery. Now in obstetrics, we don't consider normal delivery a surgery. You have drainage, simple drainage of superficial abscesses. You have acetic acid visualization to look for cervix cancer. We wouldn't consider that a surgery. It's more of a procedure. But in an underserved community, it's an important procedure that we need to support. So to answer the question, what is a surgery? Table 1.1 in DCP3 essential surgery for now is our working framework for what is a surgery. Arguably then, from that framework that is in 3 levels, the first 2 levels would correlate to district and regional, or 1 and 2. These 3 levels are called different things in Lancet Commission, different things in DCP3. To keep it simple, and I think we can be the aggregate people, that we can aggregate this back to level 1, 2, and 3, call it whatever you want. And the reason to not be too adamant about immediately engaging defining standards for the 3rd level is simply because in that arena lives fistula. They're highly supported sites already, and arguably are in the least need of guidance for ministries of health. These are where your high-stakes soft tissue reconstructive surgeries are happening for cleft, for fistula, for hydrocephalus, for eyelid reconstruction, etc. Lots of funding, lots of support, lots of externally imposed guidelines. We'll get there soon, but we're not concerned about that right now. And also by backing down to the first 2 levels, next slide please, it makes it easier for us to extrapolate the lessons learned from the BMONC, EMONC framework. And if you'll look at this framework, someone can look at this after an exhaustive day or week and immediately understand what the 2 different levels are, because these are aggregate descriptions. Our vision is that we would take what's already out there from Lancet and from DCP3 and aggregate the basic concepts to make it much more easy on the eye. What are the basic levels 1 and 2? And then we can go after defining the level 3. And underpinning all of that, in order to engage in what we titled in the first slide, Ministry of Health-Centered Design, this is coming out of the public health arena, where everyone now is talking about patient-centered design of programming and community-centered design of community outreach messaging. So rather than saying, we're going to go into remote communities and yammer all the day and night about fistula and risk of fistula and don't be in labor too long because you might get a fistula. We're backing it up in one of our largest sites in our project to talk about the risk, the real life risk benefit analysis of obstructed labor in general. It's not just fistula, it's foot drop, it's infertility, it's severe internal scarring, it's a dead baby or a baby that's severely and permanently neurologically impaired. Backing it up and making it more centered. So our goal here is to create something that a minister of health could send his or her working groups to, because what will happen, typically what's happened with fistula national platforms, and I believe also with the platforms that were spoken of just in the prior session before lunch by the ministers who were so kind to apprise us of their process, is that they most likely invested in working groups that then went out and put these things together. So we want to create a platform that a working group can use. Next slide, please. And that would involve this ecosystem. And I'm going to turn this now over to Catherine DeVries.
Thank you, Dr. Romanzi. So our group has envisioned an ecosystem approach to considering what surgical care is done and in what place. This takes into account that surgery usually occurs inside an actual hospital. So we have patients moving through a system from the community through an actual infrastructure, which includes both the place and the people and the system, and then comes out of the system and back into the community. When we're planning surgery, and safe surgery in particular, safety includes, and this came up in our conversation in our group, not just safety for the patient, but safety for the practitioners. That means the nurses, the doctors, the techs, and everyone else who works within this ecosystem. When we're talking about safe surgery, we need to consider the whole ecosystem. So we can segregate the component parts of this ecosystem, and in our G4 Alliance, we have a lot of expertise in all the separate parts. We have people with administrative experience. We have people with surgery of various descriptions, surgical practitioners. We have nurses. We have people from the environmental and hospital engineering perspective. And we know that we also need community systems that move both into and out of the hospital. That includes supply chain, municipal utilities, and backup systems for when those fail. When we're talking about low resource countries, we know that we can't operate without light. At 2 in the morning, there's nothing that can happen without light. How do we get it? We get it from electricity, and that comes from both the municipal and also a backup system within the hospital. So as we consider the ecosystem, we can define the parts, and because we have decided at the suggestion of WHO not to include guidelines, but really standards, we already have standards in place. WFSA has developed some very strong standards for anesthesia, and there are other groups that have done this too. We will be drawing from those standards and offering those as part of the package for the surgical ecosystem. As we flesh this out, it will be a very dynamic system that will be up on a website, and ministries of health can use this concept to then draw on the elements and identify the gaps.
Thank you. So the way this is occurring is that we will have this as a web page. Each individual term will be clickable and populated with hopefully a vigorous and thorough listing of available tools for direct adoption or adaptation at the discretion of the working groups that will be putting together these national policies. It was also suggested to us at a committee meeting today that perhaps we could do one of these for each of the 3 levels, building stepwise fashion on each one. We thought that was a very, very good idea. We also, if you look, so we imagine that our first job will be to populate this, which will be quite a lot. But then the second job will be to look at the community in and the community out. Now, from the reproductive and maternal health perspective, I can tell you there is a lot missing on the going into the hospital and coming out of the hospital. Your first 2 delays are coming in. Your third delay is poor care, slow care in the hospital. Then going out, what about follow-up? And in these community gaps on either side, we'll call it for now, eventually, not now, but in the near future, we have in mind to engage or make recommendation or to begin to review platforms that are available for ministries of transport, ministries of finance regarding advocating for universal health care, ministries of education, and for instance, in Nigeria, a lot of health care directed towards women is somehow administered by a Ministry of Women's Affairs. And so each country will have its own idiosyncrasies that we will use to inform not only what is available, and then over time, how is that changing? For instance, when World Federation of Surgical Anesthetists finally has their final product with WHO, that will probably trump everything we have under anesthesia. Other things will be listed, but that would immediately rise to the top. And so we will also become the dynamic go-to place. And I think that this is a substantive, groundbreaking output of the G4 Alliance that will be of great use, and we won't have to promote it. It will sell itself if we do it well. Next slide, please.
I'm having difficulty moving the next slide, so I'm not sure it can move directly. And I'm wearing, oh, there we go. That's it there now. Sorry.
And so back up one, please. Disanimate that slide. Thank you.
So,
okay.
In interest of time, Laurie, so we just need, I'm going to let you just do the final slide quickly for us.
Okay.
Okay.
So we all understand, most are surgeons or anesthetists, and we know that when we're teaching, we're teaching a lot of skills, and then that will populate procedures or operations. And the constructs is the method through which you filter, what skills am I going to put into this operation? You could do a hysterectomy many different ways. How am I pulling that through? We all understand that. There's a natural analogy we can make towards this surgical standards process. We have many existing standards. Then we have the surgical ecosystem through which they'll be filtered, which will be very individual, not only to the country at the ministerial level, but also at each site doing what it needs to take care of its community in a very dynamic engagement towards populating the protocols that they will create based on existing standards. The interface with G4 Alliance will be to streamline, categorize, and keep up to date these standards, archive it in a one-stop shopping web page, and it will be provided in a simplified 3-tiered framework. Thank you.
Thank you very much, Laurie. So in the final analysis, the whole committee is really trying to work together to reach a whole group of outcomes that we would like by this time next year to be able to have that whole dynamic set up, to have the ability for different members and organizations and ministries of health and so on to be able to click on our ecosystem, as it were, and work with that, and also to have some idea of the needs of others. So a lot of us around the table and a lot of the members of the committee will be seeking input from countries they work with and ministries they work with and so on to try and update what we've got. So thank you very much.
I thank you very much, ladies, for your collective presentation. I see Dr. Abdullah is requesting the floor. The floor is yours, sir.
So I want to thank this committee that they've done an incredible job in terms of where we've evolved from in more than a year that the group has been working. I am just so excited about what you presented today. It was so clean, so succinct, and so timely, because I think you guys hit all the issues so right in the sense that surgical ecosystems, they're complex, but I think the question we keep getting from ministries of health is what is the expectation at a district hospital? Of course, that's the most pressing need, but your idea to risk stratify on 2 levels and to define it initially, that's fine, that's wonderful, and I think, but thinking about it in a 3-tiered system is consistent with other WHO and other sort of normal language. And then if you can go back to the slide about the product, the G4 work product, I think it's also important to remember that Catherine had already began the conversations with WHO, with Walt Johnson. Even in the hallway yesterday, I was there listening around, we want to, exactly, Laurie, as you mentioned, have WHO to endorse these standards. And because then it becomes even more useful. So my only request to the committee would be, let's take it one piece at a time. So the quicker we can push these things out, the better. Having, you know, a white paper, we can do that immediately. We can publish that on our website, but we actually have multiple journal editors who've said that they would engage with us in this, and we could publish this in some of the prominent journals. So if you had, again, a V1 version of just the idea that we are going to have, this is our proposal after having worked on it for a year, that this is what our stratified system should look like, very, very, you know, a very, very big picture perspective on where you're going with all of this, that would be something we can get out there. And that's an immediate product, similar to the product that the first working group did. That would be really, really powerful. And I think that would be also helpful to inform the broader community about what our activities have been, because I don't think a lot of people know about this very important work. And it's possible, I don't think it's probable, but there's possible that there's others who've done similar work, but I don't think at this level or scale. So again, I want to congratulate you on outstanding work.
Thank you, Dr. Abdullah. We'll take one comment before you go to the other group, please.
I just have one request. Could you use the word anesthetist instead of anesthesiologist? Because this means immediately to be a physician, and we know that this is not affordable. So use anesthetist instead of anesthesiologist.
Anesthesia provider.
Or anesthesia providers as well, yes. Yeah.
I think that's an excellent recommendation. We'll go with anesthesia provider.
So one of the reasons to have a manuscript is so that we actually, similar to what Dr. Adelharder mentioned, we all need to do the wordsmithing. So for example, I can't do the wordsmithing for Alan for pain management, right? You have to do the wordsmithing for pain management. So when this committee pulls out and says at the district hospital, they can't forget, it may just be, what was the 3 words you said that need to be included? And pain management. So I know it sounds obvious, though. We just need to add those 3 words, but words matter, I think was said earlier. And so we need to hit those right words. So that's the beauty of having so many eyes looking at it, and that's what the process is about in terms of putting a white paper and a manuscript out. So check your emails. They came through for that committee. They're going to come through for this committee in the next month or 2, hopefully. So look at your emails.
Thank you.
Just to add on to what you've said, Fizan, is that one of the things our colleague brought to the table wasn't just the pain management, but was pediatrics, and to separate the pediatrics and adults, because in our standards there's a difference between the two. So for each level of unit, we're going to be talking about adult access, as it were, adult standards and pediatric standards. So there's going to be even a further subdivision, just so everyone's aware.
Thank you, Susie, for that closing comment and correction addition. May I ask that we go to item 6.3, please, which would be the presentation of key elements of developing a platform to track operative case log data, and that will be introduced by Professor Jani. Professor, you have the floor.
Thank you very much, Ambassador. We met earlier on, and we realized that there was some confusion as to the exercise that we were mandated to do. So I'm just going to issue some clarifications. The first slide shows the committee that was formed to develop the platform to collect operative case log data. Can we? No. I'll control it from here. So the task was to develop. Can we go a slide back, please? So the task was to develop only, because certain members felt that G4 was going to go and record these operations or get involved in recording these operations. But the task was just to collect the data, all right? And can we work this backwards? Okay. Yeah, the task was just to collect the data, but it's important. How is this going to be collected and how is this going to be analyzed? But we are not going to get into that. We're going to develop a platform to collect the data. So that was, these are the members of the committee. These were the members of the working group. And I'm going to do the first part of the presentation and request Eric to put in the technical details with the second part of the presentation. So I'm very grateful to the members of the group who contributed to our discussions. And why an operative data platform? Now, this is very important because there is no accurate and transparent data available in low and middle income countries. I work in a low and middle income country. I look after training in about 18 countries, with COSEXA covers now, it does training in 18 countries, and honestly, there is no accurate and transparent data collection platform there. The second thing is there were some papers produced, and the Lancet group also did work on this, in this area, but it was mainly on modeled data. There was no accurate data. So we need an accurate platform which is transparent for this thing. And we need to build consensus in this forum to come around a basic procedural case registry. It has to be a very basic thing to promote access to data and transparency, report all de-identified data. There's a lot of data which is not included in what is there on the ground. And we need to move away from estimates, because in the African countries, there is a tendency to move away from accuracy and take estimates. This does not help with policy development, so we need accurate data. The other thing that this committee realized is we do not need to reinvent the wheel. We need to build on the existing things which are there so that the buy-in by the governments will be easy. I'll come to that later on. And the platform should support quality and safety reporting. The current situation, as I mentioned to you, there is great variability. We looked at patient records, I know about this, the surgeon's logbooks, the theater registers, and if you take the data, at the end of the day, you're supposed to have a compiled, transparent sheet. It is different in all three areas, so we need to develop a platform. The second thing is there should be a dashboard at each level so that a district hospital can press a button and see how many operations were done, what type of operations were done, what's the mortality and all that. And this should be moving from the district hospital various levels upwards to the Ministry of Health, where this dashboard can be compared. The ministry can look at it and compare the various district hospitals, the various provincial hospitals, and between countries as well. So that's the thing that we're looking at. The opportunity and scope for this group, we realize that there's a great opportunity because everything that's going on in these low and middle income countries is in its infancy stage. They want to get this done. They do not have the expertise which exists in this room to give them a platform, all right? They don't have the finances to set this up, which this room can facilitate to get. So this is the right time. Electronic medical records are just coming in, electronic medical records into low and middle income countries. They're there in some countries. So we could build on this and then facilitate so that it becomes a reality. The output of the working group to be a facility to ministry system driven. That's what I'm saying. Simple. We have to work on simplicity. I'm sorry to say this, I come from a low and middle income country. If there's anything complex, the ministries will just push it away. There'll be no buy-in. So it has to be a very simple data collection system. The person who enters the data should find it so easy. The human resource is not there. Let me repeat this. The human resource is not there. Even our IT chaps who are there have very little basic IT knowledge. So this has to be a very simple system. We have to have a very common dashboard at the ministerial level, enabling simple, real-time comparison between hospitals, regions, and countries. So simplicity is of the essence here. And we need to use the pre-existing systems, and there are countries, Eric will dwell into this more, which are doing this. Thank you.
Thank you very much, Dr. Jani. Erin?
Thank you, Chair. Thank you, Prof. Next slide, please. Thank you. So, as Prof has said, LMICs are currently now in the process of moving theatre registers from paper-based to, next slide, please, to electronic format. G4 can play a fantastic role in recommending the data that be collected and the process that be used to collect the data and to aggregate the data, to summarize the data. So, for example, you have on the left-hand side of the picture there, it's OpenMRS. It's a software fees for creating medical records. Now that's open access software which is used in many countries across many LMIC countries to collect operative data. However, there is no standard as to which fields should be there, as to which data should be collected, and that's what we've looked at. Thank you. So, looking at defining, two of the most detailed fields are the diagnoses field and the procedure field, and that was where most of the discussion of our working group revolved. So we need the data to be small enough that at a facility level, at a hospital level, it's easy to find the operation, to find the diagnoses that you want to input. But we need it to be mapped to an international standard so that it can be analyzed. And we need it to be able to be summarized at a national level. So the dashboards that Prof. Jani said can be easily created. And there's some detail on what we were looking at. We also talked about how we would, what were the tools, the software, used to collect the data and to summarize the data. And there are two particular tools that we're looking at, OpenMRS, which I mentioned, and DHIS2 Tracker for collecting the data, and then a tool which is already in place in a large number of LMICs at the ministry level, DHIS2, District Health Information System 2. Which creates dashboards of data, essentially. This is what the working group has accomplished so far: defining the situation, finding what's out there, the technical and clinical parameters, reaching out to potential partners, and most of the discussion today was on the last 2 points: the minimum data set, and we were going through each of the individual fields of data to be collected, and that's maybe more information than can be discussed in a quick summary. And again, the diagnoses and procedure lists. To take it forward, no next steps, that's great. Oh, there we go. Okay, I thought my job had just got a lot easier, but okay, so we're looking at configuring those two tools mentioned to collect the data that we discussed. Selecting a small number of pilot hospitals, obtaining regulatory approval, etc., and testing out those new setups, training personnel, analysis of the data, and then completion of a recommended package. I'm glad to say that there was great participation in our group, and a number of people stepped forward to really help us out with this, and I'd like to thank Dr. Assad and Mr. Rattel particularly for stepping forward to take individual pieces of this package forward. Thank you.
Thank you, Erin. May I offer the floor to Mr. McGee, followed by Brennan, please.
So just very briefly to congratulate Pankaj Jani and Eric, and in fact all their collaborators on what they've done so far, but also to point out just that my name as chairman on the first slide shows me to be an imposter, because 1 year ago when people were asked to volunteer, I readily volunteered RCSI to do this task, but I had no intention of being involved personally, knowing that Eric was behind me. So just to say that I've had nothing to do with this except this morning. So thank the others on my behalf. Thank you.
Thank you for the correction, Mr. McGee. May I offer the floor to Brennan, followed by Tim subsequently. Go ahead.
Thank you. In my previous role, I was able to write a proposal, and we were awarded a program to audit the DHIS2 maternal health data in Laos. DHIS2 being used there was an incredibly powerful tool for the ministry, and we were basically able to get live data 24 hours after data entry at ministry level. My question or my comment perhaps is a consideration of what incentives there are for district teams or hospital teams to input data. The whole purpose of our audit was not just to identify if data was being entered correctly against patient records, but to ensure that funding from ministry level was released again when certain targets and indicators were released. It was that release of funding that was obviously the incentive that was then able to be utilised at district level. So I guess a question or comment is what is the consideration of incentive to improve data input?
Thank you. Sir, the floor is yours.
Keith Park from the World Federation of Neurosurgical Societies. So there's a pilot project ongoing in Cambodia with the Ministry of Health. And if the G4 Alliance is recommending that the DHIS2 be the preferred platform, is there an action plan planned to help synchronize the database across all the other countries? And is there a resource for technical support for using DHIS2 in places like Cambodia?
Thank you. May I ask Professor Jani and or Erin to just take note of the comments and or questions and respond at the end, please? Dr. Samad, you wish for the floor?
Yes, I'd just like to add to this a practical problem that providers face in our part of the world, and that is when there are multiple projects going on and you need to integrate them into a common platform so that when a health worker goes into a facility or a home, they are able to do so on a common platform. You know, it's very difficult for somebody to go in and take out an app or go into a hospital and use one platform for collecting surgical systems data and then another platform for collecting medical systems data and another one for anesthesia data. What we have realized is that this confuses the people who are entering the data a lot. And one of the solutions that has been suggested is to have a common user interface, allowing a more of a modular system by which different types of data sets can be collected, but the front-end user interface is the same. I'm not a technical person at all, but I understand that is easily possible with OpenMRS and some of the open access platforms that are currently available.
Thank you. Sir.
Thank you very much. Again, congratulations to the committee on their work. There's a joke amongst anaesthesia providers that you can't get surgeons to collect data, but that's just a joke, obviously. The question that I have for the committee is one: has there been any link, or is there a need for any link with ASOS, the African Surgical Outcome Study? And the second question was just looking at the tasks going forward for the committee, trying to understand again how far the G4 role goes, because you could say, well, the G4 could go as far as a consensus around what data should be collected and then making sure that that was available, ideally in an open source system, and stopping there. Or you could go further, but the go further bit is really very, very difficult. So I just wonder about that.
If I can respond to some of the questions. The incentive, as Brendan raised, I think is going to be financial, because there is a move in the African countries, at least, to have county governments now, and the funding from the federal government or the central ministry will come according to the number of operations and these things you do. So the incentive will be entering this will obviously be dependent on transparency and all these other issues. So that is going to be the most important thing. And I will leave Eric to deal with the other aspects, except for the role of G4. You're very right there. The thing that we are thinking of at the present moment is develop a platform which is sort of acceptable from the policymakers' level, meaning WHO with the WHA resolution has a very clear policy statement there saying data is required on this, and this is what we're looking at. And the other thing where the World Bank, WHO, UN have the MAG for health policy, which also says that you require this form of data, not only for surgery, they've put it across the board for clinical care and all that. So I think we need to prepare a platform which will be bought in by these policymakers, and there is a very little initial engagement with World Bank, which is trying to fund this health movement ahead, especially the surgery agenda. So there'll be some tie-in there to say that if we get a good document, the buy-in will be from by them to then use it. But we need to get a good document. That's the thank you. Eric?
Thank you. Thank you for some excellent questions. I might also start in reverse order. And well, first of all, a very simple answer. You know, although we're well aware of the ASOS study, we haven't formally explored any cooperation yet, and that's an excellent suggestion. So, I mean, I think to paraphrase Julian's question, is it are we talking about consensus on what data to collect, or consensus on how to collect the data, or both? And to be honest, we would see it as modular. The base is the data, looking for the consensus on what data to collect. A recommendation is, if you wish to go about collecting this data and you wish to transition from paper-based to electronic-based records, here's the easiest way in which to do it. Now that's a recommendation, and it's absolutely beyond the scope of the working group to sit down, to travel to a country, to sit down, to install the software. That's really far beyond it. It is just a recommendation. Perhaps at best you could download a pre-configured version of OpenMRS or DHIS2 Tracker. But yes, I mean, some people may wish to take the recommendation on which data to collect and forget about the how to collect it. Absolutely. In terms of in terms of data incentives, I know Prof. Jani addressed this, but I mean, I think it's fair to say that G4 can offer no incentives. G4 can merely provide the consensus around the around the data to be collected and the way to do it. But it's really, as with all of these things, it's up to individual countries and individual institutions to implement if they wish to implement. And of course, there's absolutely no way that G4 can, enforce anything like this, nor should it wish to. In terms of integrating different systems, we, deliberately, and as Prof. Jani said, deliberately shied away from, wanting to create anything new, so to speak, in terms of software. DHIS2 is mentioned mainly because it is what is mostly in use already. The two other software packages mentioned for data collection, OpenMRS and DHIS2 Tracker. OpenMRS is the most commonly used, and again, that's why it's mentioned, and it is integrated. There are integrations available for that data to go into DHIS2. Though I believe that's not quite perfect. DHIS2 Tracker is mentioned, which is newer, less common, but it's part of the DHIS2 system, therefore integration is easier. So that's why those two options were selected, to minimize the amount of, we don't want to propose another system. We really want to make this as simple as possible. In terms of countries such as Cambodia wishing to set up the DHIS2 system, again, it's not really the remit of G4 to sit down with a country and work through the installation of such a package. However, help is at hand from other sources. The University of Oslo has such packages, and they have quite a major system of training courses all around the world, and would certainly be willing to assist you in that, and we can put you in touch if needs be. I hope I've answered some of the questions.
Thank you very much, Aaron. I see there are two requests for the floor, and I'll give you closing commentary to Dr. Abdullah. The floor is yours, sir.
Thank you. I think Eric and Dr. Jani bring up excellent points. One of the things that was brought up was incentivization, and the discussion in the group ended up centering around we can't incentivize somebody directly, but as a platform, as advocacy platform, maybe one of the avenues to go through would be proposing these as a minimum data elements or data set to WHO and having such organizations approve these and recommend these for ministries of health and national level implementation, which might be one avenue as a group that we could decide to pursue if this is what we want to do. But direct incentivization that would be for what to collect. The how to collect would be very much a different animal.
Thank you. I can understand the rationale for using financial incentives to get buy-in to this, but I would have some concerns as to what the unintended consequences might be, because even in high-income countries where money follows the patient, there are certainly concerns that some hospitals seem to be better able to manage the process, and I use manage as a benign word, better than others. So it would be a concern if there was any major financial benefit from producing figures that were not quite accurate.
Thank you, and I also want to thank this working group for doing an outstanding job and how it's evolved over the year. Several really important points. I also want to talk about incentives. Now, remember that some of you may be wondering, sometimes we've talked about a data platform, but then we keep referring, even in the video, it refers to an operative case log. And that label actually does also refer to the incentive component. And the reason is, we heard from surgeons on the ground, and I'm sure many of us who visited the field see this, that the smallest district hospital, they have a case log. If they're doing any kinds of procedures, you will find a book where they're writing down what kind of procedures they do. You may not have nothing else. They may not have a lot of equipment for the procedures, but they'll be writing that information down. And so the idea there was that provide a value proposition for the local providers to have a platform where they could enter the data, and then even for their hospital reports, they could get some of that information back. So that, as we talked about, being Ministry of Health centered, that's very surgeon-centered sort of approach in terms of incentives. That may not be enough, to be very frank. I think we've seen that in other scenarios, but we can talk about that. The other thing that's really important also is we have to look at the other contexts of what's being done in the WHO and the global health arena. And I think focusing on DHIS is really good, and I'll get to that in 1 second. But for trauma, for example, they've established the minimum data set of trauma. WHO has done that, or is finalizing that. So in the same way, we eventually, and from a surgery perspective, will need a minimum data set around operative procedures that WHO will endorse, hopefully, and it'll be, but they want us to do the heavy lifting outside. That's always the best. So we have to think about, I would encourage the committee, same thing, think about a white paper, think about getting this, you already have probably that, you've come to that consensus or you're very close, so we can publish that as the G4 Alliance and get that out as a white paper. The other thing is it's really important, I think, the committee mentioned that you're planning to operationalize it and pilot some things in countries. That's perfectly fine. That's probably being done through member organizations, and that's exactly how the G4 Alliance intends to operate. But I think there's two things that the Alliance does really well, or should do well. We may not have done these well yet. Is consensus. I think that was mentioned. So we do consensus, and this is a consensus body. And then we have the ability to scale. So the ability, once we have success, wherever you have success or you've identified other success, if it's a member organization, maybe it's somebody outside, you should say we have the ability to offer you scale. We may not be able to get all 74 organizations to do this, but we could probably get 30 or 40 to say we want to operationalize this immediately. So I think that's also really important for us as we become ambassadors of the Alliance to really make sure that people understand it's consensus and scale is what we have to operationalize. And the last point is the measurement for health that Professor Johnny mentioned. That's the initiative between USAID, World Bank, and WHO, and I was privileged to be there when the heads of those three organizations in DC met at World Bank and launched this initiative. I think it was about a year ago. And the idea there is to really coordinate data collection, getting to Lubna's point. And they actually formally, a week ago, we haven't, I don't think Mira's even had a chance to triage this request. We were HHS as part of the U.S. congressional briefing, they formally requested the alliance to appoint, I think, 10 people to 10 different committees for that measurement for health. And those are very high-level committees where there's a World Bank representative, there's a WHO, USAID, there's a Gates representative, and just, I guess we're very lucky and that we are only one of the few civil society actors that have been asked because they see us as a coalition to sit at that table with them. So that's something that naturally you'll see some follow-up communication about. So thank you.
And I thank you, Dr. Abdullah, for your closing comments on this particular working group's work, and Professor Jani and Erin, thank you very much. And finally, item 6.4 under a presentation from Key Elements Working Group, we have the Working Group on developing a platform to track partnerships and synergies, and I will ask Dr. Shengo of Jupaigo to handle this particular item, please. The floor is yours, sir.
Thank you, Ambassador. I'll be giving a brief of like the group. There are lots of people who worked on this, so my role is essentially to present. But I don't need to explain these things to you because you all know this, but I want to just highlight how the power we have here can be tapped in this form. Dr. Lins from Massachusetts works in Madagascar. They usually do like fantastic work in Madagascar, but at the same time, while they're there, they do an assessment of the surgical capacity because they train people. As they train people there, they do know, because of the network we're having, that there is a national surgical planning meeting in Dubai. So they support the Ministry of Health from Madagascar to go and attend that meeting. The Ministry of Health now gets some information about the national plan. They come back to the country, but because they haven't planned for this kind of thing, they started to look for, what can we do? The Harvard group who's training them saying, like, you guys do have office, Jupaigo there, can you help? Then they come to Jupaigo, and we start to have this planning meeting that is happening next month. The reason why I'm saying is, just because 3 member organizations within G4 have this kind of network, we were able to get a country to, to pursue this kind of goal. The same thing with the Safe Surgery 2020 plan. GE's funding and Harvard and G4 and Jupaigo, because all of us came together, we were able to, again, take some of the discussion on the resolution forward. So this is just to summarize what we said. That is the purpose for those of you who are new to the Alliance. These are some of the things we want to achieve through this partnership platform. But that means we need to first have a common understanding whether this is of value, whether this is this is effective, or there are experience in the past that has worked. So what the team did was the working group tried to understand what happened to date in other organizations, in other partnerships, and what worked, what didn't work, what can we learn from them, as opposed to immediately jumping into a platform, because it's a huge task. But then a very important thing we did, this is again as an update, is we tried to come up with a framework of who actually needs this kind of information and what kind of information are people looking for. So we created a profile, a hypothetical profile pathway for either a healthcare worker or a surgeon, a decision maker, or whoever who wants to have information to go through a particular request of whether I need a training, or I need a supply, or I need a resource. So we tried to map those things and came up with no batteries. No, we didn't come up with no batteries. Yeah, came up with 6 components that we keep on hearing from our observation and what is happening. One, everybody agrees that we need to have access to experts, either internally or outside. Who are doing these things and where? Can we talk to these people? So that was one question. Second was, the previous working group talked about tools. What tools already exist? Who is developing what tools so that we don't develop those tools? You see, where there is also overlap within our working groups. The other is the training. I think probably most of us are involved in the training, like I mentioned. So who's doing what training and where? So that, again, we tag team and do trainings and reduce cost. Announcements. We do lots of things, but unfortunately we don't usually get the audience that we really need to have. And those kind of announcements, if we really magnify within the G4, it reached many people. And there are some challenges that we all face, and sometimes we really think of how can we solve this, data collection problem. That will be a wish list that people need to come forward and ask others who have solved this problem. So that is also something we've heard, and also anything that any partner, any member have worked on need to come out for others to access it. It should be searchable so that people can learn from things that worked and things that didn't work, that hasn't happened. So these were the 6 things that we've heard from people that a platform needs to do. So in terms of value, there is a kind of a consensus that, yeah, this is a great idea. In terms of effectiveness, though, there was question. People were saying, like, how are we going to do it? Are we asking people to upload these materials, this information, so we get all informed? Great idea, but nobody would do it. Even those people who invested a lot in doing those things couldn't really manage to have that. The other question was, having this kind of platform, will it really serve the mission of G4, which is essentially what we've heard from other working groups as well? Yes, it does, because this is how things get implemented through member organizations. But the reality is it's complex, especially if we're looking for user-generated content to come to a platform is a bit challenging. I think you've consistently mentioned that it is complex, and having a separate data platform, at least at this stage, will create a duplication of effort. I think Dr. Samad mentioned about having one user interface as opposed to a platform for partnership, a platform for operating log. So we looked at those things, and internally we consulted and prioritized our way forward into 2. So the first task will be just using the website that we have. We can really strengthen the value that we provide our members and also organizations outside the G4 to access information about who does what and where. Albulina's map was really popular after she showed it. So we can really build on to something like that using the website that we currently have, as well as the framework we created in terms of the user profile, so that we can lead people to what they need, so that start that networking process. So that will be a very specific as opposed to a large-scale platform. But at the same time, we didn't want to avoid the platform discussion, but probably start small. We have some countries who are coming forward to implement some of the surgical interventions in a large scale. So if we can identify a country where we can pilot our bigger platform idea with all the 6 components, learn in that country, and see what we can fix, and like Fizan has said, see if we can scale it up. So these are the 2 tasks that our team, after discussion, recommended. After discussion and pending the agreement of the members, we are really geared towards developing a proposal and a budget for these 2 chunks of activities, identify a pilot country in a very consultative process, and develop a kind of an implementation plan before our next meeting in December, essentially getting ready for implementation starting January. The reason why we wanted to really talk about this budget and work plan is all of this thing, and what we've heard from observation and interviews, all of this thing will not happen if there is no dedicated resource and people who manage it. Any addition from members? Matthias?
Yes, thank you, Dr. Tiggy, for a very good summary of what we did over the last year. We have been a working group that has been struggling a bit with this problem because it's really difficult if you come with the idea of a platform that will cover everything, and it will be user-generated, and it will be up to date. That's the most important thing. It will be sustainable. That's so incredibly difficult. So we thought we should start a bit small, exactly as you explained very, very nicely. And what came up also during these discussions is how much we already have, and it's not visible enough. So our member organizations are doing beautiful things. This morning, it was a very good example of Minister of Health, Al-Oghli, who explained about the cardiac surgery in his country, how it has been done with 250 operations for only 1 million instead of 3 operations for 1 million if you bring the patients to Germany. So these kind of examples we can show. We can learn from each other. We can create space for each other in the already existing network of the G4 Alliance to strengthen the organization, because I think that's what an alliance is. It's as strong as the members, and the more we can show the pearls of every member organization, the better and the stronger we will be.
Thank you very much, Dr. Botman. I see there's a request for the floor, several requests. Can we start here?
It almost sounds like to me that you're looking at a customer relationship management system, which from past experiences is a nightmare. And we're still not, my former job, we're still not out of it, and we've been working on it for 3 years. And then you would be looking at individual members of the G4 Alliance to contribute to this customer relationship management system. I mean, in some ways, I think that's what we need to aim for, but I wouldn't pilot it like this, because that's not the aim. I guess the aim is to have a common platform so that everyone is on this platform, and at a click of a button, you can get, with surgical fields, you can get an idea of what's going on in surgery, trauma, obstetrics, and anesthesia. So you need to have a tool, which is a CRM system. And what CRM system you handle, you pick and choose, has to be compatible with the goals that you want this tool to achieve. Now, there's many of them on both sides of the pond that do the job well, but you have to go out and search for it. But because of the makeup of this organization, of this alliance, which relies on the different organizations, you cannot expect the 4 employees centrally at the G4 Alliance to input all of this data, the schedules, and everything else. It's impossible. So then each of our organizations has to take it upon themselves to update the calendars, update the content, update everything else. And I can tell you that I have enough trouble just keeping up with my own. So just to put into perspective, I think it's idealistic, but with past experiences that I've had over the last 5 to 6 years with CRM systems, we still have not replaced our old CRM system. Thank you.
Thank you for your comment. May I have the... Yes, sir.
Dr. Lynch from Mercy Ships. I think this is terribly important. I think some of the discussions in some of the committees is sort of the G4's role. Certainly as an advocate, we have this target of, or potential target of 80 by 30, but the question is, how do we get there? G4 itself is not necessarily an implementer, but the power of G4 is that we have many organizations that are implementers, and the question is, how can we encourage synergies between those organizations? Because it's only through those synergies and through partnerships that we're ever going to get close to helping attain the target. So this work, whether it's a CRS system or whatever, is, I think, terribly important. It's because those connections is sort of is the power of the G4 on the implementation side.
Thank you. We have a comment here, then one there, and we'll take it after.
It's really interesting hearing from this committee, because as somebody that tries to herd anesthesiologists, I can really empathize with the difficulty of this challenge, and I wonder whether the objectives of this group could evolve in some way to reflect that. I think we can all agree that the idea is is absolutely, we all agree with the idea, but it is very, very difficult to do. So again, it's coming back to what is achievable for the G4 and its member organizations to do. And I think if you frame that around, okay, a platform that celebrates G4 partnerships and synergies. Where are G4 member organizations working together and put out those examples and celebrate those examples? And the example of going for a particular country would work really well. And I don't know whether it comes up in, under this agenda item, but I have a passionate idea or notion that if member organizations of the G4 under the G4 umbrella were to input together, for example, on national surgical plans, that would be a way in which this group could evolve in a really positive direction.
Thank you. We are very time sensitive at this point. We actually have to exit this room by 5 o'clock, and I think the most important session that we have is the one following the coffee break. So I'm going to ask, please keep your interventions under 30 seconds so we can go to coffee break and commence again, please.
Thank you, Chair. I think just to echo, I think this is the heart of what the alliance is and how can we be greater than the sum of our parts. So I agree with the previous comments. I do think asking members to do something like a CRM will not work. I agree. Tried it with different coalitions, it doesn't work because people only put in what they get out. I do think, and I know that there was a membership survey that went out, I found the level of data collection was so enormous that I don't know who had to synthesize all of that, but it's a lot. But starting with something very simple, like a list of all the countries in the world and checking off which countries we all work in. Hey, wow, look, there's one country where there are 8 members working or 10. Maybe we could have a discussion around that country and say, what can we do in this one country? And that's why I like the idea of some kind of pilot. It doesn't mean implementing a surgical plan, but how can we work together with the Ministry of Health to say, this is what you need, these are the goals, and then showcase that as an example. After that first country, maybe identify others, but simplify some of the data collection so that we know it's impossible for any of us to know what all of us are doing. So keep this simple, but again, I think this is essential to the alliance being successful as an alliance. Thank you.
Thank you.
Thank you very much, and thanks for the great work. I agree with starting simple and a lot of the comments that have been made. I just wanted to see, have you looked into the NGO aid map that was Federal Express and Gates Foundation invested probably close to $1 million into something called the NGO aid map. And since that software is already built and everything like that, we might want to do a proposal to make one for the G4 Alliance. A lot of us are Interaction members, and we use that tool pretty regularly.
Thank you for your comment. Professor Jani, we'll end with you, please.
Thank you very much. I'm going to be very brief and very simple. Tiggy, the Standards Committee had a picture of a house there showing the hospital, and I believe a drawing or a picture is worth 1,000 words. So COSEXA would draw an arrow to the surgeon and say, we train surgeons, right? And we would request that each organization point to where the input is with reference to that neglected surgical patient's outcome. And then there'll be a drop box saying somebody is visiting Malawi, and COSEXA says we need somebody to give lectures on cesarean section or teach these guys how to do cesarean section, And with that house and drop-down list, we need some IT guy to help here. That would be one way where we can achieve a lot. Thank you very much.
Thank you for a very practical approach, Professor Jani. Let me offer the floor to Mira Mahesh, and then we will go to coffee break. Mira, the floor is yours, please.
Thank you very much. We just wanted to mention, if any of you have applied for a World Health Assembly pass through G4 Alliance, and thanks to the International Federation of Surgical Colleges, Izzy and Waruguru have offered to go to the World Health Assembly next, or during this next period of time, so they can try to pick up your pass. Please go see them. They're going to potentially require a form of ID. It will save you a trip up there. For anyone who doesn't have a pass yet and would like to potentially attend, there are opportunities to do so through a day pass method. We're going to have a session, just a reminder, after the board meeting for about 30 minutes for a briefing, and we will be meeting tomorrow at the WHO to pick up those passes and for a briefing. So go see Izzy and Gugu. I know Izzy's down in that corner and Waruguru might be there as well. I just can't see without my glasses. Again, just a gentle reminder. All right, thank you.
Thank you very much, and I heartily congratulate and thank all the presenters of the working groups for their presentations and their hard work, and hopefully the comments and questions will be taken into consideration. Colleagues, we have a 15-minute coffee break. It was originally recorded for 30, but we are short on time. And I suspect following this break, we will have a very important open discussion on many of the issues that are outstanding. Enjoy the break and see you back promptly at 2:50. Thank you.
Could I make an 8-second announcement? If anybody is coming to the Bethune Roundtable on International Surgery in Halifax in 2 weeks from now, feel free to touch base with me about, restaurant recommendations and such like.
would take the responsibility of sort of moderating the conversation, so it can flow and we can take due note of the comments being made and firm up plans subsequently. So Dr. Abdullah, the floor is yours, please. Thank you.
Your Excellency, I want to thank you again for your tremendous leadership, and I'll do that towards the end as well, over the last 2 days, that you've kept us on time and literally provided us so much guidance and insight around this meeting. So I'm going to ask that the live stream, if that's being done, that should, for this session, be at least paused. We could, so for session 7, we would pause and we would go back, turn the live stream back on for the meeting close. And I know that the recording matches our live stream link, so this session should not be recorded, and for several reasons. So I think because Dear Ambassador Parson and esteemed members of the Permanent Council of the G4 Alliance, we've really come to a conclusion of an amazing 2 days. I think many of us in the room are clinicians and are motivated by the fact that so many patients are facing a lack of access to care, which is something that we mentioned at the beginning of the meeting. And this is really painful for us because so many of us in the room have the necessary skills and expertise in helping many of these families. But this specter of serving billions of patients is something that all of us have never faced before. I certainly feel overwhelmed by this challenge. But with all of you, I can say that we can work together towards a solution. And I'm sure that you've heard that many people have said that the size and scope of this problem is too big, and it's too large for us to have an impact. And that's really probably why for many years it went unaddressed. We've already had calls to action in the past. You heard in the video the Director General who used the word "I beg of you" to the surgical community that was gathered in Mexico City 35 years ago, the International College of Surgeons. And he begged them to rise up and do something because if they did not do something, no one else would. Well, my dear colleagues, I think we're at that same point in history now. I think although we've made unprecedented progress as a global movement to address the disparity in surgical obstetric trauma and anesthesia care, we're really just beginning the journey. It cannot be simply the people in this room or the organizations that are part of the solution. We need everyone to engage in this process. We have to get those people who are outside our clinical disciplines, and that's the only way we could get the whole system change and desired. One of you mentioned to me specifically that he is the only engineer in the room, and the issues around at the district hospital in terms of lack of access to water and electricity, those are really functional engineering issues. So although we have the clinical solutions, many others, as an example, that was just an example, need to be involved. But what I would ask of you is that you carry this message back to your organizations. And it's my sincere hope that if you do this with sincerity and honesty, there's no question that we'll be successful as a group. I'm definitely not promising it will be easy, and it's not been easy to get here. In fact, it will require sacrifice, and I think you will be challenged. And it's interesting, if you look at the world's most significant events that really did alter the course of human history, there was always a common theme of sacrifice, and I think this type of unprecedented striving, some component of that, some element of that is required here as well. But I hope you'll go home and be assured that I think we've made slow and steady progress here during these 2 days. And I think you may think that how are we impacting those billions of patients? But I might say to you that it's only from rooms like this that we can actually impact those billions of patients. Sometimes it's not from only the front line as we might initially perceive. But I think this will definitely happen, and it will happen because of all of you. And I really want to thank all of you for taking the time out of your busy schedules. It's been quite amazing to be among so many new friends and see old ones. I want to especially thank Ambassador Parson. I hope each of you can agree with me that he is the jewel of of this alliance. He's so passionate about this, and he's a visionary, he's a mentor, he sacrifices his time and resources for us. As this was his honeymoon. He got married 6 days ago. So I'm going to ask his wife to stand up so we can give her a round of applause. And in fact, when he told me that I told him that because I was privileged to be at his wedding, and when I received the wedding invitation, I was like, oh my God, there's no way he's going to make the board meeting. And I got on the phone with him, and he was exactly the opposite. He was like, I have to be there. I have to be there. This is so important. So I think what a blessing to have someone like him. I think, I hope to the existing board members, I know they know, but to the new board members, I think it's become hopefully obvious that we're very privileged to have Meera Mahesh be our interim executive director. And Meera is the ultimate multitasker. I think I mentioned this at the last board meeting. She can multitask on a computer as she's hitting the elevator button, going to a meeting. I mean, and be typing at the same time. It's very few people are that skilled. And she can manage many, many tasks. And you can see all of this effort and coordination of all this was due to her. So let's give her another round of applause. So actually, before I go to the other thank yous, the officers and I got Ambassador a small gift, so I'd like to present that to him, and then one to Meera Mahesh. And then we have to see the people that literally stayed up nights for an event like this to happen. There's the other G4 full-time staff. Albalena, where's Albalena? So Albalena is our membership coordinator, and I think you saw her present. And I don't know if you noticed, but when our dignitaries were coming in, and you as board members, she gives so much respect and affection to each of you. In fact, I think at one point it was very interesting. I think, Ambassador, you called on her to present a committee report. She was supposed to be presenting the committee report, or not supposed to, but she was actually giving coffee to to the board members. And then Susie, you actually started the committee report as a new vice chair. So again, the humility and the ethos and the service is just incredible. And then our latest employee is Dana. Dana, if you could stand up. Dana is our communications and development officer, done an outstanding job. Obviously, she knew that we're a newer organization, and she took a risk with us in some ways, but she also understood that over time those responsibilities will be separated. And then we had many volunteers. Our AV team, if you could stand up. Toby, can you stand up too? Toby is I would say he's probably the most overqualified AV person in the history of the world, because he's a private practice surgeon in Washington, D.C. So not many surgeons who help run AV, and we have our other colleagues there too. We want to thank you for all that you're doing. And then I think you met Izzy and Waraguru. Can you stand up, please? And we have other full-time, actually many volunteers from some, I think Maya is there and others, but Meera, I'm going to let you just take a moment to thank them, if that's okay.
Yes, thank you. So we had some volunteers joining us from around the world. They flew in on their own, and that is a credit to our volunteers. We don't have funds to bring our volunteers over, but they do come here, and we feed them whenever they have a chance to eat, which is not often, and we give them a bed, which they rarely get to sleep in. But Dina, do you know where all the volunteers are? Are they outside? Should we get them? Let's get them.
Yeah, so while we're finishing, so we'll get them and thank them. Again, I really want to thank each of you, and I would ask you to carry that thanks back to your member organizations, because it's because of their support that we're here. And I would ask each of you to really be ambassadors of the Alliance from this point forward. You are board members, and even if you're not an official board member, many of you are honorary council members and volunteers. It's only when we would show that same concern and gentleness and ethos do I think we'll have the success that we would all like. So again, our additional volunteers, Meera, do you want to just introduce them?
So we have Grace, who you heard from yesterday, and she's on a flight to Japan now, so she's busy. But Grace helped with all the technical assistance, the slides, the content, so Grace is invaluable. She's also a surgery resident, so hopefully she'll be joining us in a board position soon. And then we also have Anna, who's joining us from Germany. Wave your hand, Anna. Thank you. We have Brianne Gallo, who's an intern in our office and decided that she wanted to fly here on her own and volunteer with us for the past week. And she's been preparing wonderful communications materials, working with Albulino on membership activities, helping us with our congressional briefing. So thank you, Brianne. We have Maya. Where's Maya? Maya is diligently helping with minutes and other things. And Maya actually works, or did work with Dr. Hyder's group. And thanks to Dr. Hyder's recommendation, did?
Still does, yeah.
Still. Not anymore,
For
G4.
another month.
G4. No, Maya's actually going to medical school at, can I say it? At Duke. So congrats to Maya, over-talented, brilliant, thank you. And then we have Sophie, who just came out of a desire to volunteer with the G4 Alliance. She came with her father, who's Dr. Key Park, and has been a tremendous help to the team. Thank you, Sophie. And we also have Tom, who joined us, and he is a coordinator with one of our working groups. So thank you, Tom, for all your work. He's often on calls with the board. He's writing the report. Yeah, he's writing the report as we speak. We're written it. And then I also want to thank all of our well, who am I forgetting someone here? No, okay, thank goodness. Also, all of our interns in the office. We have 6 to 7 to 8, depending on the particular time. When I come to the office, depending on where we are in the city, there's often not a desk for me because they're working, and that's fine. So they're wonderful. I do have a desk.
Wonderful. And again, as I mentioned earlier, I want to thank the GE Foundation that helped support this meeting. So let's give them a round of applause. Again, and finally, I really hope, I think, again, as I mentioned, we're in a unique position to move forward, and I really hope that all of us can continue to work together, and it's my sincere desire and prayer that we'll rise to the challenge. Thank you.
Thank you very much, Dr. Abdullah, and thank you very much for this present. And those of you who wish to join me after the meeting, please feel free to do so. It's kind of weighty. Having said that, it's just a couple of minutes after 5, and I really wish not to go over the courtesy of the hotel to have us here until 5. I simply want to say thank you very much to all of you in participating in this meeting. Let me once again welcome all the new members and thank the participants and the returning members who made the time to come here. I thank all the chairs of the committees for the work you have done and the work you continue to do. I thank the chairs of all the working groups for the work you have done and the work that you continue to do. I would like to sincerely, personally thank the back office. Many of them have been identified here, but there are others who are not here. And they are the ones who take their jackets off, roll up their sleeves, and get the work done. Those in the back office, I thank you, those who are present and those who are not. Mira, it was a pleasure, privilege, and honor, one of humility for me, really, to work with you in the background from day one when this idea was seeded. And right now we are seeing a plant coming out of the soil and about to blossom into something we will be all proud of in time to come. And you were one of the farmers really nurturing that seedling growing up, and I thank you for that. Dr. Abdullah, my thanks to you is immeasurable. I would not even say it because I would probably get emotional. But I thank you very much for what you have done, what you continue to do, your advocacy, and your passionate plea and cry to help those who can't help themselves. You know, there's an old Latin maxim. It says, audi alterum partem. It means, let the other side be heard. That's what we are doing. We are trying to incentivize a change that many of us, we have been waiting and we have grown weary of that change. And often change is proclaimed but seldom achieved. And we are coalescing around a cause. We are galvanizing here around a theme to bring voice, in many instances, to the neglected and the voiceless. And I think you should all be extremely proud of the efforts and the time and the resources you have put out here to make this happen. Please, a round of applause just for yourselves, really. Also, let me also extend a welcome to Brendan, Alain. Brendan, I know you are sacrificing a lot. This is about sacrifice. And you're leaving your beloved Australia to come to the United States to serve this alliance. Forget the financial rewards or whatever. You are serving. That's what you're doing. You're serving. And I think we are all here to support you. In fact, I met Brendan earlier during the day, Tara and I, to, welcome him to Washington, D.C. I actually asked him, I said, come and spend a week with me in D.C. and understand how this alliance could work using the templates of others that are working for many, many, many years. And I would happily do that. And let me also publicly thank my wife, as I'm very happy to say that, we took a 3-day honeymoon, and in this beautiful resort, we spent 2 days here. So thank you very much, Tara, for all your patience. And if this is an indication of the life that we will have, thank you for the positive probation. Thank you. And let me personally commit to myself, really, to continue working with you, Brendan, and this team to bring this. This is organic. There will be no end. The G4 Alliance will be a journey. The G4 Alliance is not a destination. It's a journey, and we'll continue having to grow this from strength to strength and getting it bigger and better and wiser as we continue to grow. So to all of you, well done. Well done is better than well said. So well done. And I would like to bring this formal meeting to a close. But before I do so, let me just remind you, we have Issy and Dr. Owanjon, who presented yesterday on the WHO Advocacy Briefing and Coordination Session, and they would be here for the next half an hour or so at the Executive Suite, suite number 819, awaiting your hopeful interest in coming and engaging them so they could also take this agenda forward. So again, to all of you who may have to leave sooner rather than later, bon voyage, be safe, thank you for coming, and hopefully see all of you tomorrow afternoon.
Tomorrow at 6 p.m.
At 6 p.m., same time, same venue, the Honeymoon Suite. Thank you very much. And this meeting is hereby adjourned. Thank you.